friends, and good morning and good afternoon if you are from other part of the world. We are doing this webinar, Challenges in Managing Lymphomas in 2022 with 15 international guest speakers. It began on 11th of September, it continued till 15th of September. These are our 15 distinguished guest speakers. You have heard 6 of them already, and you're going to hear 3 of them today. This webinar is brought to you by Mumbai Hematology Group. It is supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, the Executive Committee of Mumbai Hematology Group, all our faculty members who are very prominent leaders in their own field, all our discussants who are eminent hematologists and medical oncologists from India, and you participants for sparing your Monday, rather Tuesday evening, afternoon or morning. Do remember to visit the website of Mumbai Hematology Group. It is www.mhgindia.com. MHG for Mumbai Hematology Group. There is no password and you'll have an access to all our academic activities. Today is day 3 and we have 3 lectures. One on harnessing the power of immune system in NHL, immunomodulators, checkpoint inhibitors and beyond. Second one on Hodgkin lymphoma frontline therapy. And the third one on strategies for aggressive T-cell lymphoma, divide and conquer. It's now my privilege to introduce our first guest speaker of the day, Dr. Stephen Ansel. I don't think he requires any introduction. During this whole pandemic, he has helped us repeatedly with webinars. To complete the formalities, he is professor and consultant, Division of Hematology, Department of Internal Medicine, Mayo Clinic, Rochester. He earned his MB, CHB, and PhD degrees at University of Pretoria in Pretoria, South Africa, where he also completed internship in internal medicine and surgery, residency in internal medicine, and fellowship in medical oncology. He then moved to US and completed residency in internal medicine, followed by fellowship in hematology oncology at Mayo Clinic. His research focuses on investigating the phenotype and activity of intratumoral T cells and developing strategies to modulate the T-cell infiltration B-cell lymphoma. Further areas of his research interest include the development of biologic therapies for NHL, Hodgkin's, and Waldenstrom. The current strategies being developed include the use of novel antibodies and cytokines, the use of targeted therapies, and the development of strategies to inhibit signaling through receptors that promote the survival of malignant B-cell. The utility of these strategies is being tested in early phase clinical trials. He is frequently invited to give presentations on his research, both nationally and internationally, and is published in high-impact scientific journals. He is associated editor of the American Journal of Hematology, serves on the editorial board of Blood Cancer Journal, JAMA Oncology, and Journal of Clinical Oncology. He is reviewer of various scientific journals. In recognition of his work, he has received awards and honors, including the New Investigator Award, the Teacher of the Year Award in the Hematology Fellowship Program, and the Development and the Department of Medicine Research Awards for landmark contributions to the literature. I request him to deliver the lecture on harnessing the power of the immune system in non-Hodgkin lymphomas, immunomodulators, checkpoint inhibitors, and beyond. Over to you, sir.
Well, thank you very much, and really grateful for the opportunity to participate in the meeting. Thank you so much for inviting me. So I'm going to just make sure that you can see that. I trust you can.
Yes, sir.
Excellent. All right, so my task today is to talk about harnessing the power of the immune system in non-Hodgkin lymphoma. And I'm going to focus on a variety of different ways in which that can be achieved. But as I start, I just need to disclose that my institution does receive funding for clinical trials from the companies that are listed on the slide. The money doesn't come to me, but does come to my institution, and some of the trials we'll be discussing today are impacted by this funding. So the things I would like to talk about today, and some of you might have heard me talk about some of these issues in the past, but I think it's always valuable for us to refocus our attention on what we're trying to do when we're doing an immunological strategy to target lymphoma. So the first thing I want us to talk about is, if you really are going to try and get an effective anti-tumor immune response, particularly T-cell mediated, what exactly is that? And are you, when you're doing things, achieving that? So to understand what our goal is really the first step. The second thing we need to talk about is, well, if we're not actually achieving that, what are the problems? What are the deficiencies in the immune response in lymphoma? And what I will do is share with you 4 broad categories of immune deficiency that is present in lymphoma that is challenging. There are many more than those, but I think those are 4 that we can at least start our discussion on. If we have those deficiencies, the key question then is, what strategies could be utilized to overcome these immune deficiencies or immune barriers, if you like? And that's really where I want to highlight some of the strategies for treatment that you saw in the title of the talk today. And that's really ways in which we can overcome these immune deficiencies. But I want to challenge our thinking as we go along. I think sometimes when we're thinking about immunotherapy, we tend to be pretty simplistic in our approaches. We assume just one thing is happening. But I hope that you will take away from the talk today that this is a highly complex issue with multiple different mechanisms all interfering and intervening with each other. And I think as we look to the future, we need to understand more of this to be more effective in the therapies that we develop. So as we start out, what's really important for us to understand when we're thinking about what happens when the immune system sees the tumor cell? So what I want to highlight again is that when there's actually a tumor present, a virally infected cell, or a cell that is now a threat to the immune system, what happens is that on the surface of the tumor cell, the lymphoma cell in this image here, there is presentation of antigens in the context of MHC molecules. And when that happens, that provides to a T cell the first activating response. However, it's important to know that if that's the only activating response that happens, the cell will become anergic and subsequently apoptotic and will not actually target that cell. And that's actually important in the biology of people, because if you're presenting self-antigens, you want to be very careful not to get a reaction to that. Otherwise, you will end up with autoimmunity. So this anergy is actually quite important. However, as we know well, tumor cells have antigens that are very similar to our normal antigens. So there's this challenge of what gets presented and whether or not a second message will be provided. So the second activating message comes through a co-stimulatory molecule, and typically that goes through something like CD27 or CD28, mostly CD28, but also other molecules such as 4-1BB. And you'll hear these names because there are treatments that we'll talk about later that are trying to provide an additional activating signal to provide these 2 messages, and the 2 messages are what result in an activated T cell. Shown on the bottom is what happens at the same time to regulate that whole event. So clearly, if you just have ongoing persistent activation of your immune system, it will get crazier and crazier and then actually be quite of substantial risk to the patient. So when you get this activation, as with everything in biology, you're going to get a counterbalance with an inhibitory signal. So typical inhibitory signals that calm down this activation approach are signaling through PD-1, through CTLA-4, and through LAG-3, TIM-3, a number of other inhibitory signals. So as you can hear, activation, inhibition, all happening at the same time. I'm going to talk about this a little bit more on the next slide, but what I want you to hear is these 4 different parts of what constitutes a good immune response. Recognition of the antigen, activation of the cells. The cells need to not only be activated, but they need to persist and continue to target the malignant cell. And something we really don't think about much, but is important in the whole world of immunology, and that's immunological memory. So this highlights that in a little bit more clarity in a single cartoon. So what you can see on the left is the antigen presentation. The tumor cell or other antigen-presenting cells taking tumor-associated antigens in the context of MHC, presenting it to the immune system. Then you get activation. What happens then is you get the second signal, shown here as the most common, B7 signaling through CD28, activating the cells, cytokines get produced, the cell begins to proliferate. The cell also begins to target, and the effector cells are now beginning to kill the tumor. Then you get the third part, which often is really important, and we'll talk more about this a little later on, and that's in the context particularly of CAR T cells. You need persistence. If you just have a quick peak and it goes away, not enough good things might happen in the immune response. You need, and really to date, we don't actually have evidence that that happens in tumor immunology. So what I want to do is to show you that having thought about what is a normal immune response, I want to show you at least 4 areas in which that normal immune response isn't really happening in lymphoma. And that's part of the reason why the lymphoma cells will evade the immune system. So the 4 things I want to highlight to you are, remember how we said antigen presentation was important? I want to share with you data that says that actually that's a problem in lymphoma. Secondly, you heard me say that an activating signal was needed. I'm going to tell you that many times in lymphoma there are many negative signals when you need a positive signal. Thirdly, you're supposed to really have ongoing support of the immune system, but there can also be control of the immune response. And I'm going to show you that in lymphoma there are many suppressive other immune cell populations present in the microenvironment that will actually suppress the immune response. And finally, you've got to remember it's not just cells, but I showed you that various cytokines are made in response to this immune activation. Some of those are positive, some of those are negative, some of those are positive, but too much positive results in negative. And I'll show you that that is also something that is substantially at play in the lymphoma context. So to take those one at a time, I'm just going to show you limited amount of data from various types of lymphoma to make the case that these issues are all a reality when we're thinking about immunotherapy. And when we simply think that we can poke a T cell and make it work, we have to remember that the T cell has a lot of issues that it has to overcome. So issue number 1 is the loss of MHC molecules and expression of MHC. So remember, if MHC molecules are not expressed, the tumor antigen is not being presented in a typical, usual way, and T cell activation through the T cell receptor may not occur. So here is data for Hodgkin lymphoma. This is work done by Margaret Ship's lab a few years ago, but all it does is it shows that in a number of cases, when they looked at staining for MHC class 1 or class 2 or beta 2 microglobulin, all key components of the MHC complex, only a small minority of the cases had everything just right. Most of them were missing something, suggesting that in Hodgkin lymphoma, in a disease where we see a lot of immune therapies being very active, MHC is actually profoundly impacted by the changes in the tumor environment. You might say, well, that's Hodgkin lymphoma. Well, here's data, and it's actually almost 20 years old, to show that the same is actually true in large cell lymphoma. So here is just showing now MHC class 2 molecules and showing that those are typically lost in large cell lymphoma. You can see on the B panel B, those are the number of cases where there is a significant loss of the molecule, and that is directly related. Loss of MHC class 2 is related to an increased risk of death, now shown almost 20 years ago. So the second issue, so first issue being if MHC molecules are not well represented on the cell surface, possibly antigen is not well presented to the tumor or to the immune system. Issue number 2 then is even if antigen is well presented, even if there is a T cell receptor engagement and activation of the T cell with message number 1, often what happens at the same time is that instead of getting the second positive signal, there is overexpression of negative signals. So many, again, would be quite familiar with this data. This shown on the left is Hodgkin lymphoma, shown on the right is diffuse large B-cell lymphoma, and the same issue is true here. This is now PD-L1, PD-L2, highly expressed on Hodgkin lymphoma because of genetic amplification or copy number gain. But that might be unique really for Hodgkin lymphoma, maybe primary mediastinal large B-cell lymphoma and some testicular or CNS lymphomas. But shown here on the right is just your typical diffuse large B-cell lymphoma. And actually, if you look for PD-L1 expression, it can be increased even in large cell lymphoma. So shown in blue is the expression on tumor cells, but shown in green is the overexpression in the microenvironment on macrophages. And shown in the bottom panel is if you have more expression of PD-L1, that actually results in a poorer outcome. So you might say, well, how does that happen? Here is data from follicular lymphoma showing that when you have high expression of the ligands, you actually inside the tumor have T cells that are very susceptible to those ligands. So shown in panel A is looking now for cells that have a phenotype that would make them vulnerable to signaling through PD-1. And you can see the TIM3 positive, PD-1 positive, the potentially immunologically exhausted cells are very highly represented within the tumor. Shown in panel B is those cells are actually ones that are really immunologically deficient, and shown in the gray peaks, you can see they don't really proliferate compared to the white peaks, which are the normal ones from the tumor. And shown in panel C, they do not make cytokines, and in panel D that their STAT signaling is inhibited. So the point is the ligands are highly expressed on the tumor, and the T cells are very vulnerable because they have this exhausted phenotype with high expression of PD-1. So problem number 2 is instead of a positive signal, many of these cells may unfortunately receive a negative signal. And this is additional data from other groups recently published. This is a discussion of those PD-1, TIM3 positive with a focus on the CD8 population. You can see on the left that there are more of these cells that are unable to proliferate. That's the cell trace DIM cells. You can see that their ability to proliferate is inversely proportional to the number of these cells. The more cells they have, the poorer they proliferate. And shown on the far right, the more cells there are, the less cytokines they make. So again, many groups have shown that these vulnerable cells are present within the tumor. The third thing that I think is important that we said, so again, number 1 was not enough presentation of the antigen. Number 2, a negative signal rather than a positive signal. But number 3, and I want to highlight this here, is that it's not just about the effector cells. There are many other cells present within the microenvironment that are not helping to allow the immune system to do its job. So this is, again, follicular lymphoma. You can see the H&E staining showing those multiple pseudofollicles. You would, if you stained for CD20, just see plenty of CD20 positive cells. But what I'm highlighting here is the other cells. So shown at the top, you can see CD3 is actually a lot of CD3 positive cells present. So why are they not fighting the tumor? Why are they not getting rid of the tumor? Why does the tumor keep progressing? Shown on the right is CD21, and those are follicular dendritic cells, again defining those pseudofollicles and again supporting the growth of B cells. So if you dive a little deeper and you go right into one of those follicles and you look to see, are those cells CD4 or CD8s? Actually, CD4s and CD8s are well represented. The challenge, however, is that if you look which CD4 cells those are, you can see actually many of them are T regulatory cells. So you see the expression in that same follicle now of FOXP3. Shown on the top, you can see that FOXP3 positive CD4 and CD25 positive cells are much more prevalent in lymphomas. And if you take those cells and you co-culture them with other cells, shown on the bottom left, you cause those other cells to have the inability to make cytokines, and as shown on the bottom right, they don't proliferate. So what does that mean? More Tregs stunt and suppress the immune environment. Additionally, we often have an appreciation of many of the monocytes and macrophages present within the tumor. So in panel A, you see a stain for CD68. That kind of captures most of those kinds of cells. You can see that actually they're very prevalent. Shown in panel B, I'll talk a little bit more about cytokines in the upcoming slides, but they often are responsible for cytokine production, and many times the cytokines they make either overstimulate the immune system or suppress it. But they may have a direct effect to actually allow for tumor growth, and that's shown on panel C. You take those intratumoral monocytes and macrophages, co-culture the malignant cells with them, they grow much faster. Shown on the bottom panel D, we actually did a xenograft model. This is a mouse where we inject the tumor cells either by themselves or with monocytes and macrophages. And you can see if you put monocytes and macrophages with the tumor cells, they implant far faster. This is yet another population. So you heard me talk about Treg cells. You heard me talk about monocytes and macrophages. Here you see me talking now about myeloid-derived suppressor cells and their role. So you can see this again is taken from patients. You can see that there's this population of lineage negative HLA-DR low, and then they're also CD11B and 33 positive. As you can see on the far on panel B, they can either be a CD14 monocytic derived or a granulocytic CD15 positive myeloid-derived suppressor cell. And you can see both of them also express these inhibitory ligands, including PD-L1. Shown across the middle is the fact that these are more prevalent now in the bone marrow. We were looking specifically in this case at a disease called Waldenstrom's macroglobulinemia, but you can see that they are more prevalent within the tumor. And shown across the bottom, when you take those myeloid-derived suppressor cells, co-culture them with the patient's own T cells, the presence of those myeloid-derived suppressor cells very much suppresses T cell function. So yet another population present in the tumor or in the microenvironment that actually shuts down immune function. Again, those particular cells they have a phenotype that is driven by cytokines. So you see at the top, the HLA-DR low CD14 positive phenotype. You can see in panel B that more of those are associated with less proliferation. But the point I'd like to make here is that cytokines actually promote these kinds of cells. And here we show that IL-10 is the culprit. If you take monocytic cells, co-culture them with IL-10, you will generate this suppressive phenotype. And the reason that matters is that when we've looked at patients with B-cell lymphomas, they may have more IL-10, and that IL-10 will actually promote this suppressive environment. Well, why are cytokines important? So this brings us to the fourth issue. So again, you heard not enough antigen presentation, too many inhibitory signals, too many other cells present that really inhibit the ability of the cells to proliferate and activate, and this soup, if you like, or this environment of cytokines, various of which can actually significantly impact immune function. So I'm going to highlight here just two cytokines that profoundly impact the immune response. First is TGF-beta, shown at the top. If you treat T cells with TGF-beta, you can show activation of those cells. That's CD70 goes up as they become activated. But as you can see in the remaining panels across the top, those CD70 positive cells have all of the wrong features. They are high in PD-1 expression, they are high in TIM3 expression, suggesting that they are now activated but also dysfunctional. As you can see across the middle, they don't proliferate very well and they don't make cytokines, and if they do, they make cytokines that promote Treg cells. So what does that tell us? TGF-beta is actually generating this immune dysfunctional and suppressive environment. Interesting finding for us across the bottom is IL-12, which can also cause immune exhaustion, but this time because of repeated activation and stimulation. Way back in the day, we actually treated patients with IL-12 plus rituximab, as a treatment for follicular lymphoma, and saw that that was actually a worse treatment than just rituximab alone in a randomized study. And the reason was shown on the bottom. If you look at patients who have elevated IL-12 levels at the time of diagnosis, these are follicular lymphoma patients, they do worse compared to the patients that have normal levels. And the reason is IL-12 activates the cells, but persistently does so, and by continually activating the cells, it generates an exhausted phenotype, as you see the TIM3 PD-1 positive population go up. So again, this ongoing activation all the time is not good for the immune response. So take that all together. there are many other mechanisms which impact immune function, but I just wanted to highlight at least these four and show you that with the lymphoma cell in the center, our goal to have an immune response that can target that lymphoma cell. You can see that the effector cells are typically exhausted and dysfunctional. There are other cells present that are very inhibitory and regulate in a negative way that immune response. And there is a cytokine environment that does not help to create a good anti-tumor immune response. So goals for what we're going to talk about next is how to fix that. And the two things that I think are important is you need to work to reverse this immune dysfunction or exhaustion, and you need to work to overcome the other mechanisms of immune suppression. So the key question is, how on earth are you going to do that? So I want to share with you 5 different strategies, all of which address exactly these issues that we've just been talking about. And the question is kind of critically looking at it to say, how well do they work? And as we're learning about them, what are some of the lessons we can take away? So strategy number 1 that I do think is really important and has been very relevant in not just lymphoma, but other malignancies in general, is just as I mentioned to you, the key problem is that instead of an activating signal, very commonly there's an inhibitory signal. So if you just simply could block that inhibitory signal, you could create greater degree of anti-tumor T cell activation. So shown here are a variety, and there are many more, of immune checkpoints. You can see that on the left-hand side are the inhibitory checkpoints, on the right-hand side are the activating checkpoints. So the strategy could be to either block the inhibitory signal or provide an additional activating signal as a way to do that. And again, most people in the room and listening online here would be aware that this has been highly successful, particularly in Hodgkin lymphoma. So these are 3 patients that were originally treated on the first of the phase 1 clinical trials of nivolumab in Hodgkin lymphoma. And I show this because I think each of them teach us something interesting. So the patient on the left, you can see, has a very modest amount of lymphadenopathy. This patient had relapsed after a transplant and was treated. And the reason I show you is this patient got 2 years of nivolumab, treatment was discontinued, and this patient has never had the disease recur, now about 7 or 8 years out from that treatment. So it does suggest that in a subset of patients, there may be a long-term durable outcome. I'll show you in a minute that's not everybody, but certainly, as I say, there may be some. The patient in the middle, I think, is very informative. This patient, as you can tell on the PET scan, has a lot of intra-abdominal lymphadenopathy, and you can see that responded beautifully after 6 weeks of treatment, and the patient was in a good response. However, if you're an astute clinician and looking at that PET scan, you can see there's increased uptake in the chest, which has not gone away. Interestingly, this patient was actually diagnosed at the time of having a valve replaced, and that actually is part of the healing process post-surgery. So the thing that I think is a learning there is that immune responses that are anti-tumor are differently affected than immune activation that is in part of the healing process. The patient I show on the right is the first patient I treated with nivolumab, and you can see that this patient had an excellent response, but it wasn't a complete response, still some FDG uptake in the armpits. The interesting thing for this patient was the fact that he was treated for 2 years. The protocol then required us to stop. The patient then about 8 months later had disease progress again and got retreated and actually responded right back to the level of response before. So I think the lessons there are that you can stop the treatment and restart with good success. Just going to show a little bit of updated data, relatively updated. This just is follow-up of the pembrolizumab trial. You can see a variety of different cohorts here, post-transplant with brentuximab, no brentuximab. But I think overall you can see the majority of patients benefit. The reason for showing this is the duration of response curve on the right. While I did show you that there are some patients where the disease does not recur, you can see that unfortunately this curve continues on a downward slide, suggesting that we are not really achieving the immunological memory that we spoke about right in the beginning, and there's clearly still additional work to do. There have been a number of newer PD-1 antibodies also showing high efficacy. Here is tislelizumab, and you can see that the reason I showed this is that a very high complete response rate in this trial, 63%. With longer follow-up, it's going to be important to see if the complete responses actually translate into a longer-term survival advantage. Now, I think there are a few other things that are really important because there are a few lessons learned which I want to highlight here. So I think what we've learned is that copy number gain and amplification of PD-L1 are clearly associated with responses to PD-1 blockade. But the challenge is just what exactly is happening. So these Reed-Sternberg cells clearly are benefiting from this very high expression of PD-L1. And as you can see, this results in very high expression, the copy number gain and amplification, and is associated with improved PFS or even OS. When we look at other areas in which this is beneficial, you can see that encouraging response is seen in other diseases where amplification and copy number gain is seen. This was an update of 2 studies treating primary mediastinal large B-cell lymphoma patients, and the key here is that you can see about a 50% overall response rate. Additionally, patients that seem to benefit substantially are those where there is another reason for overexpression of PD-L1 and PD-L2, and in this case, it's EBV. EBV will drive that process as well, and in the NKT cell lymphoma patients shown here, you can see this is a small series, but again, there have been responses that have been seen in those patients. In contrast, in unselected patients where there isn't an amplification or there isn't an EBV-driven process, the responses have been very disappointing. And you can see here, this is now overall response rate in follicular lymphoma was only 4%. Overall response rate in diffuse large B-cell lymphoma, 10% overall, 3% in patients who had primary refractory disease, suggesting that really simply taking away this inhibitory message isn't very effective in these unselected follicular and large cell patients. So why might that be? So I think we've learned a few things along the way, and I wanted to highlight this here. And this is again where I want to challenge us as a community to really critically think about what we're doing. So the first thing I think we have to realize is that while PD-1 is expressed on exhausted cells, just because a cell expresses a PD-1 molecule doesn't mean that it's necessarily exhausted. And why is that? Shown in the top right here on the A panel, you can see that there are PD-1 bright cells and there are PD-1 dim cells between the follicles. The bright cells are in the follicles. And we've done work to show that the bright cells are T follicular helper cells and quite different from the dim cells, which are really the cells with the more exhausted phenotype. The second thing that we found that was quite surprising is that PD-1 cells, expressing cells, very commonly make more cytokines than PD-1 negative cells, because when you activate a cell, PD-1 goes up. So simply expressing PD-1 could actually mean you're an activated cell rather than an exhausted one. Shown on the right is when other activation markers like LAG3 or TIM3 are expressed, those cells are very suppressed. So simply having PD-1 doesn't make you suppressed. Having PD-1 plus LAG3 or TIM3, that makes you a very immune exhausted cell. So why is that important? Well, simply blocking PD-1, you could be blocking any one of these different populations of cells with a very different effect on each one of them. And that may be that if some of those cells dominate in certain diseases compared to others, the results may be different. The second thing that I think is really important is how exactly does PD-1 blockade work? And I'll show you that in the next slide, but I need to show you some data here to say that these immune cells present in the tumor may not be very helpful when we think we're going to actually stimulate them. So this is data from follicular lymphoma, and you can see here that tonsil shown at the top in panel A, follicular lymphoma below it, looking now at CD28 and 27, those key co-stimulatory receptors, you can see that they are less in follicular lymphoma, and that's shown in summary across in panel B. And the reason that matters is if you have more cells that are now no longer expressing 27 or 28, those are associated, more of those cells are associated with a poorer outcome in follicular lymphoma. So why might that matter? Well, there were 3 or 4 papers now 5 years ago that showed that when you block PD-1 in various diseases, you get preferential signaling that comes now through 27 and 28. Obviously, if you don't express 27 and 28, you can block PD-1 all you like. It's not going to actually turn that cell back into a useful cell. So we have to recognize that we may be working with cells in the tumor microenvironment that are very much suboptimal. Even that we think everything is happening just in the tumor. And here is data to show that PD-L1 and PD-L2 are easily cleaved from the cell surface and soluble in the environment. So you can see this is in Hodgkin lymphoma, Hodgkin sera showing significantly higher levels than normal sera of both PD-L1 and PD-L2. And the reason that matters is that if you take that sera with the PD-L1 and PD-L2 and you treat activated T cells with it, it will suppress the T cell function. And shown across the bottom is some of the mechanisms by which it works. And the seahorse analysis in panel D shows that the metabolism of those cells are completely shut down. So why again does that matter? Well, we think we're doing everything in the tumor, but actually we may be doing things distantly, and actually it might be about the tumor macroenvironment, the whole patient, that actually may be relevant. This is a little bit of additional confounding data just to say it might be that actually overexpression and amplification of PD-L1 or PD-L2 is really important for the survival of the tumor cell directly, rather than an immune thing. So here we show that if you actually use a stimulatory antibody and bind to PD-L1, that's shown in panel A, you get what's called reverse signaling. So signaling back through the PD-L1 ligand to activate the cell. So basically that's a T cell naive or T cell agnostic event. It really is done because of the PD-1 binding. And again, just like PD-L1, PD-1 can be soluble. And shown in panel B on the top, you can see higher levels in the serum of soluble PD-1. And if you take that soluble PD-1 and you treat the cells just with the soluble PD-1, those Reed-Sternberg cells will proliferate, and you can block that with the use of nivolumab. So the reason to show you that is that there may be other mechanisms aside from an immune response relevant in particularly Hodgkin lymphoma. I think this is only important when there is a genetic reason for overexpression of PD-L1 or PD-L2. So that was strategy number 1. Strategy number 1 was to block the inhibitory signal. Now I'm going to talk about strategy number 2, and that is, well, if you don't have good antigen presentation because of loss of MHC, how could you overcome that? So again, shown on the left is what we would like to see, and that's tumor antigens being presented in the appropriate fashion. But as everyone on this call knows, the use of CAR T cells may help to overcome that. So what you would do now is you would create an artificial docking, if you like, of the T cell to a tumor antigen using an antibody binding motif, as you can see at the top, which is then coupled through a co-stimulatory segment that will activate the T cells. And as everybody knows, and I'm going to show you some limited data now, is that you have really good results in B-cell lymphomas. We're seeing now good results in myeloma. We're seeing some promising results in Hodgkin lymphoma using different types of CAR T cells that dock onto the tumor with a co-stimulatory domain that switch those cells on. And I think the encouraging thing, particularly in B-cell lymphomas, now in large cell, mantle cell, and follicular lymphoma, is that these responses look very durable, which I think is particularly of note. So that was strategy number 2, overcome the lack of antigen presentation by using a CAR T cell. Well, a third strategy is basically force T cell activation by using a bispecific antibody. So what I'm showing across the top is kind of the general principle of how this works. Shown across the bottom are the different constructs, and you can see there are a variety of different formats of how these work. But in general, they work entirely in the same way. So pretty much what happens is there is binding to the tumor antigen by one part of the antibody and then binding to the immune cell with the other. And the thinking is that that brings a immunological synapse really close together, and as that happens, that activates the T cell, generates perforins and granzymes and other things that target the tumor and make the cell die. Now, I will tell you that as we talk a little bit about this data, I'm going to challenge you to think about that. So sometimes we get this naive idea in our heads that when we infuse this into the patient's arm or give it under the skin, it goes on its own, dodges everything in the blood until it gets to the tumor and does all the work right there. It might be, to be frank, that it's grabbing T cells all the way along and bringing those T cells, maybe they're fresh T cells from outside of the tumor, into the tumor to have it do better work. Also, those cells are potentially becoming activated in the periphery, and that may be changing that immune environment, particularly the cytokine profile. So I don't think we completely have our heads around how bispecific antibodies work. We're just really grateful that they do. So the first one of these was the BiTE or bispecific T cell engager. This was blinatumomab. You might remember this is a very small molecule. That's why the half-life is very short. But I would show you here, this was the original data in large cell lymphoma with an overall response rate of nearly 70%, 55% in large cell lymphoma, proving that you can utilize this strategy with good results. Now you know there's been a bunch of data subsequently. I'm just going to highlight some of them. This is mosunetuzumab. It's a CD20 instead of the CD19 for blinatumomab plus CD3. And this was the original data showing large cell lymphoma on the left and follicular lymphoma on the right that showed a good response in many of them. And those responses in the benefiting patients was quite durable. This is additional data from a different CD3, CD20 bispecific. This is odronextamab. And you can see this data also showing that the responses are promising. And as many on the call will know, actually, even in CAR T cell failed patients, those are patients that benefit from this therapy. An additional way in which we could utilize this to force activation is now not to force T cell activation, but to force NK cell activation, or maybe NK cell or monocyte activation. So this is also a bispecific antibody. This is AFM13, also a small molecule, a little different. You can see binds CD30 on the tumor, binds CD16 on the NK cell or on the monocyte or macrophage. This has been tried on its own with kind of modest activity. Here it's being used in combination with pembrolizumab, trying to get a dual effect, engaging NK cells and engaging the T cells. And you can see the response rate here was 88%, which looked very promising. But clearly we would need to do a randomized trial to see whether this was really an additive effect or just a patient selection effect. I would like to highlight some data that was just presented at AACR just a few months ago, which I thought was really interesting because remember I said a bit earlier about how we might naively believe everything's happening in the tumor and not in the peripheral blood, and probably there's a lot of binding happening in the peripheral blood. Here was a study that actually took advantage of that. So taking cord blood derived allogeneic NK cells, activating them, and then preloading them. So adding the AFM13 ahead of time so that pretty much you have an NK cell already bound to the CD16, now just looking for a CD30 positive cell. And these cells were infused a little bit like an NK, like a CAR T cell with the same fludarabine cyclophosphamide therapy. And actually in a very relatively small study, now about 20 patients, overall response rate of 90% with a very high complete response rate. Most of the patients were Hodgkin lymphoma patients. There were a few patients with T cell lymphoma. So again, I would say that this is early data. This is a small study, but the proof of principle is that potentially bringing in fresh effector cells rather than trying to wake up old and sleepy ones that are present in the tumor, that may be an effective way to go. You can also see that the responses are quite durable. Follow-up is short, it's less than a year, so I think we have a lot of that still needs to be done as far as follow-up in this trial. But certainly, as I say, in multiply refractory patients, some of whom have even had an allogeneic transplant, this was encouraging work. So strategy number 4 is to say, what could we potentially do about the innate immune system? So most of what we've just spoken about is the adaptive immune response. This is your T cell response. But could you maybe use the innate immune system, the macrophages and the monocytes, which we know are not usually good because they often are quite inhibitory, but can we take those bad cells and turn them into good cells? And we know that that's potentially possible because we know that when you use rituximab or other antibodies, macrophages are often the cells that do most of the work. And so you can turn those cells into phagocytic cells. But you'll also know that the tumor got wise to that and overexpresses do not eat signals. So CD47 is shown up at the top in number A there, is very highly expressed on the tumor. And it sends a negative signal to a macrophage through SIRP-alpha that says, give me a pass, leave me alone. Now, if you could use an anti-47 antibody, or as shown here, a decoy covering up antibody to SIRP-alpha, if you could put that on a coating, if you like, on those CD47 molecules, suddenly an eat signal through calreticulin or another molecule like that would be the dominant signal, and the macrophages would do the phagocytosis. So you can see down in D, the tumor cell is now being phagocytosed, and the reason that matters is not only the phagocytosis, but the processing of that phagocytosed cell and then the presentation to the T cells of now T cells or tumor-associated antigens in the appropriate context to get better T cell activation and then more efficient anti-tumor cytotoxicity. So could that work? Well, here is some lab data to say absolutely. And you can see that CD47 across in panel A is highly expressed on tumor cells. But if you cover that up, shown in panel B, you can get macrophages, which are the red cells or monocytes, to eat the green cells, and they'll eat multiple cells. And shown across the bottom is if you use antibodies like rituximab, that's shown in the middle, you'll get some degree of phagocytosis. If you cover up 47, like with the SIRP-alpha, you can get more of it. And if you do that together, you can actually get very effective phagocytosis. So does that work? Well, again, here's some initial data using an anti-CD47 antibody plus rituximab. And you can see overall response rates of about 40% in patients overall, and some subsets of patients having even higher responses than that. Here is the decoy receptor, the SIRP-alpha FC molecule, and you can see again responses seen in a variety of patients, either as a single agent or in combination with rituximab. Clearly, there's more work to be done here. Bispecific antibodies using that in combination with CD19 or 47 blockade in combination with PD-1 are all in development and early clinical trials. This just shows that it works not just in B-cell lymphomas. These are data in T-cell lymphomas in Sézary syndrome. In a small set of patients, there was a higher response rate. And then finally, well, I think it's important to recognize that combination approaches are going to be needed. And I'm just going to highlight a few combinations that are currently in process. A few things that didn't work well, and I think it's important to learn from that. And this is a combination of two negative immune checkpoints, PD-1 blockade and CTLA-4. That's worked well in solid tumors. But you can see here that in other hematological malignancies in panel A wasn't particularly good. Then also, could you use an NK inhibitory blocking antibody? That's lorilimab, and you can see again in combination with nivolumab, that was not effective. But could you use a blocking antibody such as nivolumab in combination with an antibody drug conjugate? In other words, you're targeting the tumor to release antigen, and then you're activating the immune response. And you can see here with brentuximab vedotin plus nivolumab, a response rate of 82%, looking something that we're using more and more standardly these days. Clearly, you could use it then in combination with chemotherapy. And I show this really because sometimes it may be important to clear the decks, as it were, and get rid of all these dead and very inhibited cells, allow fresh cells to come in, and then modulate the immune system. And here it's use of PD-1 plus AVD chemotherapy, and you can see a high response rate across the board. That's also been now tested in large B-cell lymphoma, and again, going to require randomized trials, but some early clinical studies have shown high response rates, both in overall response rates and complete responses. So as I end and then allow time for questions and comments, what does this teach us? Well, I hope you've got an appreciation of there are really many immunological barriers to an effective anti-tumor response. And I think we need to understand that it's not easy to just do one simple thing and think that that's going to fix everything. The biology is quite complex. I think genetics matters because overexpression of some of these ligands based on genetic reasons actually may predict who benefits and who doesn't. I think we need to be a little careful not to be overly simplistic, recognizing that we do different things to different cells, and CAR T cells, bispecific therapies where we are forcing activation really look very promising. But as I stressed, we may have more to learn about exactly what we're doing. And then finally, combinations I think are going to be the future. We're going to need to do different things to get the adaptive immune response more activated, various things to bring the innate immune system into the picture. And then finally, I wouldn't throw out the cytotoxic agents just too quickly because I think there's still merit with using them as well. So with that, I'd like to end. I'd like to thank the lab members that generated some of the data that I showed you, thank the folks that give us the money to allow us to do the work, but mostly thank you for this invitation and for your time and attention and joining us today. Thank you so much.
Thank you so much. That was such a fantastic lecture. Very, very innovative ideas and a lot of learning for all of us. We have some of the colleagues here. Some of them may be interested in asking you some questions. Not that it was a very easy subject for us to digest. In 45 minutes, lot of basic science. So we'll wait for some questions. Meanwhile, can I ask you one question? Is there something like tachyphylaxis when you start stimulating the immune system to attack the cancer cell? Slowly, do you keep losing the response? Like you mentioned a case where you can second time give nivolumab and it worked, etc. But is there an observation that when you use it second time, third time, the effect wears away?
Yeah, I think that's a great question. And actually, to be honest, I think nivolumab or pembrolizumab are kind of unique that way. That's not usual. Your comment is that re-stimulating the immune system often is negative. So for example, if you look at the data for a reinfusion of another CAR T cell, like a second dose of CAR or a third dose of CAR, those have not been very effective at all. Similarly, there's now some data to say that if you can stretch out the dose of bispecific antibodies a longer and longer periods, you actually allow for the T cells to wake back up again and not be overstimulated. If you give them too close together, you may get less of a result. So you're right on. I think one of the challenges we're going to have to learn is how to activate and then rest, and then activate and then rest, not just simply pound away.
Thank you. That was fantastic. Yes. Dr. Bharat, your question.
Thank you, Dr. Stephen. Very interesting lecture and very basic mechanisms. I was just wondering, with HIV-associated lymphomas and T-cell response, and now in this era with effective antiretroviral therapies, if CD4 count has improved and there is immunocompetency, how you see the T response? And second, in future, can you are seeing any role of immunotherapy and CAR T cell therapy in such HIV associated adequately controlled with ART?
Yeah, so very good questions. So the first thing I think that we've learned is that if you have well treated the HIV and restored the CD4 count and basically immunologically improved the patient, many of the immune responses, including transplants and things that we would like to do, the results actually look very similar to patients that are HIV negative. So to your point, I think it's quite appropriate if you have the patient well treated to always consider utilizing those therapies for the patient. The second point you make is really important, and that is, could these kinds of approaches be used directly to actually treat the HIV? And to be frank, I haven't seen any data to suggest that yet, but there is a lot of data targeting other viruses, EBV, for example. So there are cellular therapies targeting EBV as a way to treat cancers. particularly Hodgkin lymphoma and NKT cell lymphomas and the like. So I think as we learn more moving down the road, I think we're certainly going to be able to see treatments that are be used in a much kind of broader context. So great question.
Thank you, sir.
Thank you, Dr. Bharat. So how do you see the sequencing of all these things? So many things coming up, bispecifics, CAR T, now this 47. So what's your vision about the future? How will these things be sequenced?
Yeah, so again, I've really been appreciating the work that's being done of testing these things in randomized fashion. So again, as I'm kind of thinking about things, I certainly see frontline treatments now in a number of diseases being improved with the addition of an antibody drug conjugate. So either brentuximab vedotin or polatuzumab vedotin now moving into frontline approaches. I also see now in second line approaches many of these immunotherapies, particularly CAR T cells, and to be frank, there's some really interesting data in high-risk frontline patients maybe benefiting from CAR T cell therapy. I see the bispecifics, I see some of the other CD47 strategies kind of coming behind at this point. However, if you look to the future, I think actually giving bispecifics may be a lot simpler, if particularly once you get familiar with them, than giving CAR T cells. And so it could be that in the future, we'll see the bispecifics leapfrogging right up to the front, but we don't have data for that yet.
Thank you. If you get a serious immune-mediated disease while using these agents like nivolumab, then how do you sort of see the future of that patient? Does this go on for very long? The immune-mediated complications?
So that,
yeah. Yes.
That ends up being quite a challenge. You're quite right. So quite frankly, one thing we have learned, particularly in like Hodgkin lymphoma and diseases like that, the use of steroids can actually still suppress those immune effects, but still maintain the clinical benefit. So I think there is opportunity to maybe hold the drug, utilize steroids, calm things down, and then keep a lower dose of steroids and utilize, for example, PD-1 blockade and maintain the benefit. If it turns out you're not able to do that and the immune effects end up being too great, then I do think that kind of unfortunately takes that treatment off the table and makes you go on to other things.
Right. So, anyone else would like to ask any question to sir?
Hello.
Yeah, go ahead.
I'm Dr. Narendra. There's a small question about using steroid concomitantly with the PD-1 inhibitors. So, Dr. Stephen and Dr. Agarwal, in your opinion, at what doses of steroid we can use concomitant steroid and this thing PD-1 inhibitor, pembro or nivolumab? Any limit, any dose for steroid, any safer dose of steroid which doesn't blunt the effect of PD-1 blockade, in your opinion?
Yeah, so again, I think it really comes down to, it depends on the disease and it depends on the immune effects. So if the immune effects are pretty profound and they're actually life-threatening to the patient, I think the patient's health and well-being is the priority, and you need to use as much steroids as possible to get the patient under good control from those perspectives. Second thing is, it depends on the disease. So I think if you think in Hodgkin lymphoma, that's why I showed you the data around reverse signaling. It could be that it's not a T cell thing. And so then you can actually use quite a lot of steroids and it probably won't matter that much. But in general, I think I've found in my practice, if you can get down to the 20 milligrams of prednisone, you can actually safely get benefit both ways. So I think, that's kind of been my strategy to try and get down to that level.
Good. Thank you, sir.
Is using rituximab to control the immune-mediated problems safe?
Yeah, absolutely. So, I think rituximab, all of us are very comfortable with it. It's pretty safe therapy. Obviously, the one challenge in the world of COVID has been that may put you on a little bit more risk in that, but that's fortunately now, I think, waning, which is good. So all told, if I put it all together, if that's an optimal strategy that you could use, especially if it's a B-cell lymphoma, you get 2 for 1 and I would certainly consider that.
Talking about DLBCL, you showed that these agents are not very effective. Now, medicinal large B-cell lymphoma, I suppose the relapsed patients can be helped with the help of nivolumab and pembro.
Yep.
There's a big
Yes.
difference between the two.
Yeah, so I think the big difference between the two is the fact that primary mediastinal large B-cell lymphoma looks a lot like Hodgkin lymphoma when you look at the genetic profile, and it's this PD-L1 amplification in at least half of the patients. So the problem, the benefit is if you have the genetic amplification, those people clearly benefit. If you go back and look at the large cell lymphoma, just the unselected, very few of them had a PD-L1 amplification. And in those patients, they didn't really benefit. So I think that's where in the future, large cell lymphoma, we're going to need to do combinations. Just simply taking away the negative signal is not enough. You need to provide some degree of activation of the immune system at the same time. So that's why when I ended and spoke about combination approaches, I think that's going to be important.
And which of these approaches are better for CNS lymphoma?
Yeah, again, good question. So a number of them are a little challenging because we want to make sure we can get at those cells. But there are now some data in CAR T cells showing that CNS lymphomas can be treated. And I would also say that we've seen some benefit with PD-1 blocking antibodies in a subset of patients. So all told, I think there are some patients that that benefit, but we have small numbers and need more work.
Any more questions for Dr. Stephen?
I see Dr. Advani is joining us, so
Yeah,
I just wanted to say hi to her and thank you again for having me.
Thank you, sir, for sparing your time and being with us. It was very, very educative. Thank you. Thank you.
Thank you very much, everybody.
Wonderful day. Yes.
All right. Bye-bye now.
Welcome, Dr. Ranjana Advani. I'll just introduce you formally and then you can take over.
Sure.
So, friends, our next speaker, of course, is an extremely known personality, Dr. Ranjana Advani. She requires no introduction. I'm just doing a formality. She's professor of medicine at Stanford University, specializing in the field of lymphoma. She holds an endowed chair, Saul Rosenberg Professor, and oversees all aspects of treatment of most adult lymphoma patients. She also serves as the disease management group leader for lymphoma and supervises the clinical program. Her primary research interests include improving care of NHL and Hodgkin lymphoma patients by optimizing the frontline regimens, developing novel agents and targeted therapy for refractory and recurrent disease, advancing correlative value studies involving biomarkers, and addressing long-term outcomes. She leads multi-institutional efforts as a national study principal investigator or co-PI on several targeted therapies, translational and imaging studies, and has published extensively in the peer-reviewed literature. She's a member of the Lymphoma Core Committee for the ECOG and NCCN Guidelines Committee for NHL and Hodgkin lymphoma, Vice Chair, member of ODAC to the FDA, and has completed a term serving as the co-chair of the National Cancer Institute Lymphoma Steering Committee. I invite her today to speak to us on Hodgkin lymphoma frontline therapy.
So thank you, Dr. Agarwal, for the kind invitation. And I am going to share my screen with you. So just give me a second so that I can. Are you able to see my screen?
Yes.
Okay, let me just go to the slideshow. Okay, so I'm going to speak to you today over the next 35 minutes or so on frontline therapy for advanced Hodgkin's lymphoma. These are my disclosures. So the learning objectives are to summarize the current first-line therapy options for advanced stage classic Hodgkin lymphoma and to review the novel and emerging agents or modalities that may be incorporated as first-line therapy options for patients with classic Hodgkin lymphoma. So as a way of background, classic Hodgkin lymphoma represents approximately 10% of all lymphomas And in the US, it's about 9,000 new cases annually. It's highly curable with frontline therapy, even in advanced stage disease. And at any given time, there are more cured survivors than patients with active disease. So in 2022, what are the goals of therapy and expected outcomes? So for advanced stage, which is defined by and large as bulky stage 2B or stage 3 or 4, we expect a cure rate of anywhere from 75 to 85% with standard therapy. So the therapeutic priority of all the research which is happening or is going on is to actually increase the efficacy, but at the same time decrease the toxicity as well. So the dilemma of the choice of frontline therapy was, should we be doing ABVD or should we be doing escalated BIACOP? And that was based on a balance of the cure rate and some morbidity because of toxicity. So it's the intensity of therapy or the extent of therapy. And ABVD was sort of this tried and tested thing where everybody all over the world knew how to do it. It's very well tolerated. And escalated BIACOP was somewhat better, at least for progression-free survival, but it was a heck of a lot more toxic. There was heme malignancies, there was a lot of grade 4 hematologic toxicity, and more importantly, infertility. And Hodgkin's is a disease of the young. So that's why it was like, well, we don't really want to do escalated BIACOP for everybody. ABVD is sort of easy to do. It cures maybe less patients, but how do we pick the few patients who might do better with escalated BIACOP? And that was the debate which for the past 15 years or so was being worked on. And using an interim PET adapted strategy helped sort of sort that question out, where the goal of the interim PET adapted strategies was to actually limit the toxicity. So 2 therapy strategies were employed. Some studies started out with ABVD, and then based on the interim PET after 2 cycles, either escalated or de-escalated the therapy. Or another strategy was you start out with the escalated BIACOP, and then again, you can go up or down based on the interim PET. And for advanced stage, most studies considered a Dovel score of more than 3, that means 4 or 5 as being positive, except one of the German Hodgkin's study groups, the HD18 trial, which used a more conservative definition, and even Dovel 3 was considered as a positive therapy. So keep that in mind as we go through these studies. And as I mentioned earlier, many of these studies did include bulky stage 2 as part of the advanced stage algorithm. So I'm not going to go into every study in every detail, but these 3 studies sort of illustrate the work of the past 15 years or so, which use this interim PET approach. So the first one was the Rathel trial, which gave 2 cycles of ABVD, and if you were PET negative, that means a Dovel 1, 2, or 3. Bleomycin was omitted from cycles 3, 4, 5, and 6, and so you just give AVD. It did include stage 2 unfavorable. In fact, about 40% of the patients had stage 2 bulky disease, and about 18% had a high IPS. Nonetheless, at a median follow-up of 5 years, you can see that getting rid of the bleomycin actually had no detrimental effect at all. And in fact, you got rid of that 5% pulmonary toxicity completely. And the 3-year progression-free survival is 84%, and an overall survival of 97%, because the patients who failed this approach could be salvaged with different regimens. Now, if you restrict the analysis to patients who had stage 3 or 4 disease in the Rathel trial, the PFS is about similar, it's 82%. So for patients who were PET positive, actually therapy got escalated to BIACOP. And in those, the PFS is about 70%. So better than historic controls where you continued ABVD, but certainly not at the level of being PET negative. The other study was the LISA study, which used the other way. You start out with escalated BIACOP. And if you remember, escalated BIACOP has evolved. The German Hodgkin's study group used to give 8 cycles, then they came down to 6, and then 6 where radiation was restricted to sites which were greater than 2.5 centimeters. So they've been dialing back too. And in this AHL 2011 study, the question was, well, if you're PET negative after 2 cycles of escalated BIACOP, do you really need to continue with escalated BIACOP, or can you sort of downgrade to ABVD? And that's what was tested. So 2 of escalated BIACOP, PET negative, randomized to continuing with escalated BACOP for a total of 6 or going down to ABVD. And you can see again, at a median follow-up of over 5 years, the PFS of the experimental arm is excellent. A PFS of 88% and overall survival of 97%. So sparing a lot of patients the excess toxicity of the extra 4 cycles of escalated BACOP. And then the last study was the German HD18 study, which tested, do everybody really need 6 cycles of escalated BACOP? Or can we get away with just 2, a total of 4, if your interim PET is negative? So in this study, if your interim PET was negative after 2 of escalated BACOP, one of the arms tested looking at just 2 additional cycles, and the other arm continued for the standard 4 for a total of 6. And again, you can see that at a very mature median follow-up, the 5-year progression-free survival is excellent, 92%, suggesting that if you're PET negative after 2 cycles of escalated BACOP, you really don't need to do a whole other 4 cycles. You could just get away with 2 more. Again, reducing the exposure to escalated BACOP, thereby reducing the overall toxicity. So these 3 examples illustrate what the field had been doing with interim PET strategies. And this kind of just summarizes it in a tabular form. And so what does interim PET allow us to do? It allows us to safely de-escalate therapy. It can allow us to omit bleomycin. It can de-escalate from BACOP to ABVD, or it can decrease to a total of 4 cycles. But what we don't have a very good handle on is what is the best strategy for escalation if you're PET positive on interim PET. So, the studies I showed you did escalated BACOP as a escalation measure. But there is an Italian study which did transplant, and those results look pretty good. So they didn't waste time if they were positive if ABVD do escalated BACOP. They went straight to a gemcitabine-based regimen and then went on to transplant. And the issue, of course, is if you are PET positive after getting escalated BACOP, what do you escalate to beyond escalated BACOP? So those are sort of the unanswered questions. But at least if you're negative, I think we all know and are comfortable with using PET-adapted strategies. So then comes brentuximab, which is the antibody-drug conjugate, and that was tested against standard ABVD in the Echelon-1 trial. So you gave ABVD times 6 versus brentuximab AVD times 6. So no bleomycin when you gave brentuximab. And just recently, Dr. Ansel presented at ASCO, and then just published in the New England Journal. We participated in the study as well, that at the 5-year mark, the progression-free survival advantage of about 7% stays. And now with longer follow-up, there is about a 5% survival advantage for the brentuximab arm, which is the first time in Hodgkin's we're actually seeing a survival advantage. And I'm going to walk you through these details a little bit more. So if you look at which subgroup benefits from the brentuximab containing regimen, if you see older people who are over 60, there's actually not much benefit. If you look at the low IPS 0 to 1, there's not much benefit. Most of the benefit is in patients with an IPS of 4 to 7. Again, stage 3 doesn't have much benefit. It's mainly in stage 4. And for some unknown reason, females don't seem to do as well as males. So there are subsets who do very well, and like IPS 4 to 7, or if you have stage 4 disease, clearly the overall survival advantage is in favor of the brentuximab AVD arm, and sort of a no-brainer decision. But for these other groups, I'm not so sure the writing is on the wall. So let's sort of look into details about why there is an overall survival advantage. And if you can see that the main reason more people died on the ABVD arm were second cancers, 11 versus 1, which is unheard of. Think of how many decades we have all used ABVD. Which study has reported increased second cancer without radiation being part of the mix? This is only for stage 3 or 4 disease. So there was no radiation to get at a median follow-up of 5 years. So this is not late cancers, which come later. So you can argue that, okay, well, maybe more patients failed ABVD, so went on to transplant, and that's why they had more hematologic malignancies. Well, let's look at that. So if you look at the solid tumors in dark here, equal, 14 cases in both arms. So it's not the solid tumors. So it indeed is hematologic malignancies, which is more, 9 cases in the brentuximab arm and 17. But is it AML and APL after transplant? The answer is no. There are only 2 cases of AML over here. And over here, there is also only 2 cases, one AML, one APL. So those are the same. This excess is largely because of 13 cases of B or T cell lymphoma. So on diagnosis at death or relapse, it wasn't Hodgkin's. It was B or T cell lymphoma, and there were more in the ABVD arm than in the brentuximab arm. And you worry that this was a sort of maybe there was an error in inclusion time, and there was no central pathology review. So were these people actually T cell lymphoma or a CD30 positive B cell lymphoma who were erroneously called Hodgkin's and were put on this trial? And then, of course, it's logical that if you have a CD30 positive lymphoma and you get the brentuximab arm, you are going to do better than getting ABVD. So that difference might be explained by that, but again, that's speculation. So as I explained, the transplant rate is very similar in both 7 patients, 9 patients. So that certainly is not an answer. So the current choice of therapy, a dilemma of therapy, is actually now, should we be doing brentuximab ABD for all patients because of this overall survival advantage? Escalated BIACOP still has excellent results. Or should we be doing the RATHL approach for ABVD? And again, it's a balance of cure versus morbidity and the intensity or the extent of therapy. So what are the considerations in echelon 1? One is the comparator was ABVD and not ABVD given for RATHL, where the pulmonary toxicity has already been reduced and you get rid of the bleo, so you don't really see that excess pulmonary toxicity. And as I explained to you, this whole second cancer business, I don't understand very well, but it could have been a path error or truly that brentuximab has some effect on stem cells and it's protecting it. But the impact is largely on stage 4 disease, younger patients, and high IPS. And I think that's the group where it's almost now with the overall survival advantage that most centers, at least we have switched to giving BV-ABD to that subgroup. And of course, there are cost considerations. So if you look at the financial toxicity of adding brentuximab to a frontline regimen, because you need growth factor support, you cannot give it without growth factor. You can see that the 6-month course of ABVD, at least in the US, which is about $3,500, goes up, to almost $300,000. It goes up significantly. So the acquisition cost for BV would have to go down by almost 75% to sort of justify this approach. Now, there was another model created which compared all these approaches, compared the RATHL approach, compared starting out with BIACOP, compared the echelon 1 brentuximab ABD or just giving ABVD. And actually what came out as a winner was starting out with the AHL approach, where when you start out with 2 cycles of escalated BIACOP, and if you are PET negative, you drop down to ABVD. So actually you can drop down to just AVD because we know that even after the RATHL, if you're PET negative at 2 cycles, you don't need the bleo. So you can get rid of the bleo completely. And that sensitivity analysis showed that the model was very robust to these key variables, including the probability of treatment-related mortality, relapse, second malignancy, and death. And that was the most cost-effective way of treating Hodgkin's lymphoma. Now, brentuximab is being evaluated with other combinations because it certainly is a very active drug. And the Germans are looking at 2 regimens called BRICAD, or the BRICAD regimen was compared to another regimen, BRICAP, and came out as the winner. So BRICAD is being compared to escalated BIACOP in the German Hodgkin HD21 study, and we haven't heard any results. And again, the goal is reduce the toxicity. You don't have to give the 6 cycles. You can cut down to 4, and maybe by adding brentuximab, you can get rid of some of the high alkylator, which was used, and switch from procarbazine to dacarbazine, which is much less hematologic toxicity, as well as cut down on the bleomycin dose. Now at ASCO, the pediatric, one of the pediatric studies also confirmed that adding brentuximab did improve outcomes. So this was the pediatric AHOD 1331 study, which uses the pediatric regimen of AVEPC. So the one arm got brentuximab, the other one didn't. And you can see this was, again, they did interim PET, but therapy really wasn't changed. And radiation therapy was limited to if you had large mediastinal masses, or there was protocol defined. And you can see again, like in the adult study, there's about a 7% improvement in event-free survival. So again, yet another study where at least progression-free survival is improved by addition of brentuximab. Now, brentuximab is not the only novel agent which is moving into the frontline setting. So I know Steve Ansel talked to you about checkpoint inhibitors in non-Hodgkin's lymphoma. Well, where it is extremely active is relapsed Hodgkin's. And nivolumab and pembrolizumab are approved for relapse disease. And so, of course, now studies are ongoing, both in early stage and in advanced stage, and in advanced stage to improve upon ABVD or BVAVD. So this was the keynote, the 205 study, which was sort of proof of concept, where there was a lead in with nivolumab for 4 doses, and then patients went on to combine nivo with AVD, and then they were followed, trying to see how patients did. So you can see over here that this was presented by Dr. Ansel at Lugano last 2 years ago. And you can see that at about 2 years, the PFS was about 83% with this approach. And if you look at the interim after 2 cycles of the combination, there was no difference in outcome between PET negative and PET positive, suggesting that this approach might also be very promising. And what was quite significant was at the end of therapy, if you were PET negative at the end of therapy, you did much better. So, often we get a question, well, the interim PET is negative. Do I really need to do a PET scan at the end of therapy? The answer is yes, because in about 5 to 10% of the patients, it can switch from interim negative to positive. And actually, those are the patients who have the worst outcomes. So based on the results of this study, there is an ongoing US intergroup study for patients with advanced Hodgkin's, so just stage 3 or 4, no bulky 2. And it's just straight nivo AVD. So there's no lead in or anything. And it's being compared head to head with brentuximab AVD. And it's for 6 cycles. So there is no interim PET scan done, because the Echelon 1 study didn't do interim PET. The data were collected, but that wasn't used to escalate therapy or something. So it's the same study design, but head-to-head comparison of nivo AVD with BV-AVD. And this trial has accrued more than halfway, and I think will be one of the next most important trials to see if the standard of care will change or not. Now, Pembro has also been looked at in the frontline setting. This is a study, again, which we participated in along with Jane Winter's group at Northwestern, a small study with starting out with Pembro instead of nivo. It's just 30 patients. But if patients had PET, they got 3 cycles, they got a PET. And if they, irrespective of sort of the PET status, they continue to get chemotherapy. And it was a total of 4 to 6 cycles of AVD based on bulk and stage. So you can see over here that at the 3-year follow-up, the progression-free survival and overall survival is 100%. So amazing results now at 3 years. And they tried to, in this study, which was just published in Blood Advances this week, that looking at the expression of PD-1 pathway markers and did a level of expression correlate with outcomes like in lung cancer it does? Well, the answer in Hodgkin's is no. You could have just very little expression and you still have an amazing response. So checking for PD-1 expression in Hodgkin's is useless because it doesn't correlate with response. Okay. Now, Ryan Lynch, one of my former fellows who's now in Seattle, evaluated a different way. They gave Pembro along with AVD, and they sort of, instead of a lead in, but they sort of sandwiched it. And you can see, again, this is also a small study, but you can see just the PET2 after 2 cycles, the CR rate was 66%, which went up by the end of 6 cycles to 81%. And again, at 16 months, which is pretty short follow-up, the PFS was 96%, which was excellent. And they saw some immune-related toxicity like transaminitis, but it didn't really lead to any discontinuation. It led to some delay, but it wasn't no discontinuation and no further increased toxicity. So again, looking at yet another way of yet another checkpoint inhibitor in the frontline setting. So while we're making advances in therapy, can we do a better job of identifying patients who have a high risk of treatment failure at the beginning? So, interim PET helps us after the fact, end of therapy after the fact. Do we have biomarkers, or do we have something which we can use at diagnosis? So there are emerging things. One is called the TARC level. Then, of course, there are PET parameters beyond oval score, the whole field of circulating tumor DNA, and then some other things. So this is just TARC level. And you can see over here, without going in all this detailed text, that if your TARC level, if your interim PET negative and a TARC level is low, you do really very well. And the worst group is the ones who have a high TARC level as well as interim PET positive. And then the two groups in between, where you could be interim PET negative but have a high TARC level, or PET positive but a low TARC level, you kind of do in between. So it's, there is a limitation. All these tests are not, specificity, sensitivity is still an issue. But nonetheless, it is a clue that there are other emerging biomarkers which can complement our PET results to see what, how patients might do. This doesn't get rid of the problem of at diagnosis, because there are people in this study over here that who had a high level, but only about 43% of them failed. So it wasn't 100%. Nonetheless, an emerging biomarker. And then this was looking at interim TARC versus interim PET. And again, showing that it had a positive predictive value, which was higher than the interim PET, 88% versus 47%. Again, it's interim, not at baseline. So at baseline, something called the metabolic tumor volume is emerging as a score, which is helping identify patients in whom a more intensive therapy than just giving ABVD would be more useful, while avoiding escalation for those who could have a high chance of being cured with the ABVD approach itself. So they looked at the metabolic tumor volume, and you identify a score, and you can see that irrespective of the IPS, if you have a high score and you have a low IPS, you still don't do very well. But if you have a low score, irrespective of what the IPS was, patients do quite well. So you can use metabolic tumor volume as a starting point rather than using an SUV. And this is again looking at interim scan and metabolic tumor volume. Again, a retrospective analysis from the German trial, illustrating the same thing. So you can see in gray here is at baseline a low metabolic tumor volume and a low IPS. They do really well. In contrast, in blue, you have a high metabolic tumor volume and a high IPS. Okay, so if you have both those things at baseline, you're not going to do well with an ABVD approach. And then in between, in yellow, is you have a low tumor metabolic volume, but you have a high IPS, and you kind of fall somewhere in between. So in this group, you may not necessarily have to, start out with the most intensive or the most expensive regimen. You could get away starting with less, and if required, move on. Whereas in the group in blue, giving them an ABVD-like approach doesn't really make sense. Okay, now there's something called the Dmax, the dissemination feature, which looks at sort of the distance of the tumors, and and over here you can see if the Dmax is greater than 20, the outcomes are worse than if the patients have the Dmax less than 20, and that also correlates nicely with interim PET. So again, over here it's a high Dmax and a positive interim PET. This is negative interim PET and a low Dmax, and then in between. And then, of course, circulating tumor DNA, you can see that correlates that if again, at baseline or on interim and end of treatment, if you have residual circulating tumor DNA, it portends a worse prognosis. Now, again, all these nothing is ready for prime time, but this is where the field is moving to see if we can develop these biomarkers at baseline, which might help us stratify patients. The other thing which really is humbling is that outcomes do depend on the expertise of the center. Okay, so if you see less than 10 patients a year with Hodgkin's, it's not considered a center of enough experience. So if the facility is just seeing, 3 to 5 patients or 3 to 10 patients, you can see the outcomes are significant. The survival of those Hodgkin's patients is much worse than by a center or an individual who's seeing at least 10 a year. And, practice makes one perfect. So we are trying to tell everybody that if you are in a situation where you don't have experience, reach out to centers which have the experience, refer to the NCCN guidelines, because no one can keep up with the rapidly moving field, but to gradually try to sort of either get the expertise or follow guidelines or speak to the experts, because this is a highly curable disease and your first chance is your best chance. Okay. So how do I treat advanced classic Hodgkin's? I think based on the echelon 1 survival advantage, if people have high IPS, stage 4, and they're younger and fit and they don't have any neuropathy, I give them brentuximab AVD. If they have a low IPS or they are older people, I treat them per RAPL and I do PET adapted ABVD. And of course, if they're older than 60 or they have neuropathy, I again use ABVD per RAPL. So it's I do use a lot of brentuximab AVD, but I am a little cautious. I just don't use it for every single patient. And this slide, I'm going to dedicate this lecture to my mentor, Saul Rosenberg, who taught me everything I knew about Hodgkin's. He passed away last week. And he was one of the legends in lymphoma. And he taught us right in the beginning that you pick one disease, you study it well, and it will take you to the ends of the earth. And that's what Saul Rosenberg, along with his colleague Henry Kaplan, did for Hodgkin's disease. In the 60s, this was a highly fatal disease. And now this is one of the most curable disease that exists. And it's sort of the poster child of oncology. And we should be striving to do that for all conditions. So at the end of the day, frontline therapy is balancing risk with benefit for an individual. It's a combination of risk adapted, response adapted, the resources you have, how patients are tolerating everything. And the goal is, of course, the highest cure rate with primary therapy, and you optimize your survivorship, because there are more survivors in this world with Hodgkin's than patients with Hodgkin's. And we owe it to them that we give them therapies which preserve fertility, which allow them to lead normal lives, because these are young adults and they have at least 30 years more of life, if not more, after their Hodgkin's treatment. So as a community, we have to come together and support the trials which look at long-term outcomes so that we can treat our patients appropriately. And that is my last slide, and I'm happy to take any questions.
Thank you so much, Dr. Advani. That was wonderful. Dr. Krishna Ratnam, your question.
Thank you very much, Dr. Advani, for excellent lecture. I had the question is pertaining to the interim PET. So you very clearly said that the interim PET has an excellent value in de-escalating therapy and reducing the toxicity. But my question is, if the interim PET is positive, very often we have this clinical dilemma. You have 2 patients with interim PET is 4, double score 4. How do you approach after ABVD? And interim PET 5, what do you do? These 2 scenarios after the interim PET.
So which is very, which is a very practical question. We see this at the clinical level on a daily basis. And I think 5 is easier to handle than 4, because 5 clearly is either a new site of disease or a growth of existing sites, or someone hasn't responded at all, and we would biopsy it. And unless it's something which the writing is on the wall that there's disease everywhere. I think 4 is more difficult because there are lots of shades of gray. A 4 can be, you have a big mediastinal mass which has, shrunk down a lot, and you have one little area in the, in this big mediastinal mass, which is slightly above the liver, and it's called a 4. Versus, you have multiple areas which are a 4. So often if the patient has responded clinically, the SED rate has gone down, the B symptoms have gone away, the hemoglobin's improved, I would give another 2 cycles and do a short interval PET without changing therapy. And very often you find that just, continuing with ABVD or whatever you've started out with, the problem goes away. I mean, like the next scan after 2 cycles, instead of waiting till 6, you do it after 4 and it's become a CR. If, however, it still persists, then I have a very low threshold to biopsy these patients. just to make sure we're not missing a gray zone lymphoma or something else.
And if the biopsy turns out positive, you take them for salvage therapy.
Yes, and so the choice of salvage therapy, I didn't show you the Italian study, but that looks very good too, that if they're positive, you give them a, they did a gemcitabine containing regimen, AGAV, and took them to transplant. And that's what would be the standard of care is, and consider post-transplant radiation to that one particular site, which was a slow responder.
You don't change to escalated BCOP.
You can. Many centers, it's easier to do salvage and transplant than escalated BCOP. So it depends on the infrastructure you work in and what kind of support you have.
Thank you. Thank you very much.
Thank you, Dr. Krishnan. Dr. Dibendu.
Hello, excellent lecture. My question is regarding the pediatric Hodgkin's lymphoma. Do you still use ABVD as the first-line therapy for pediatric Hodgkin's lymphoma or any other regimen?
So, I have to plead ignorance on that because I don't see pediatric patients. So I'm certainly not the expert to advise on what the first-line regimen is. So I'm not going to claim that I know much about pediatric. And again, it comes from working in a center where we're so our pediatric oncology is so separate from adult oncology that I haven't really had to deal with the pediatric. Anyone over 18 comes to me, anyone less than 18 goes to the pediatric side. And every now and then we have a common protocol which we share, but I won't be able to give you a proper educated, data-based answer. So pardon me on that.
Thank you, Dibendu. Any more question from you?
Thank you, sir.
Okay, Dr. Shilpa.
Thank you, madam, for a wonderful talk. My question is, in those pembrolizumab and nivolumab trial which you have showed, does the nivolumab stop after like 6 cycles of nivolumab AVD, or do we give a maintenance for 2 years beyond that?
No, so that stops. Okay, so
Okay.
the study which I showed you, which is now the basis of the US intergroup study, it's just given for those 6 cycles. Okay, there is another international study which has just completed accrual, which we have submitted to ASH, where we actually gave some maintenance with pembro afterwards, but that is not standard of care. It's only in the relapse setting where you give a longer duration for the frontline. And none of these checkpoint inhibitor frontlines are ready for prime time. We don't know the randomized trial results as yet. That's the reason to show it to you was, while BVAVD has mature results and an overall survival advantage, the trials comparing that to a checkpoint inhibitor AVD are going on.
And one more question, if I may ask.
Yes,
sure.
Yeah, this is following a CAR T. Like if there is a patient post CAR T who has relapsed, there is a definitely role for immune checkpoint inhibitors, in which case there are people who have tried Nivo or Pembro. And if so, like how frequently do you give it? Is it the same protocol which you follow in a normal like relapse
Wait,
setting?
you're talking about CAR T for Hodgkin's?
Not for Hodgkin, sorry, for DLBCL. I'm sorry. This is.
Yeah, so why are you using for post-CAR T? Why a checkpoint inhibitor for relapsed? You're talking about non-Hodgkin's relapse post-CAR T?
Yeah.
Okay, so
Sorry.
there is no protocol using it. It's still being evaluated. Okay, there are some studies which show marginal level of efficacy. Lots of things are being tried in that setting, including BTK inhibitors. And it's certainly not the standard of care.
Yeah, thank you.
Thank you, Shilpa. Dr. Arihant.
So my question is regarding the Hodgkin's lymphoma who present with a lot of extramedullary and hepatic involvement at baseline. They are jaundiced, high ALPs. So what is your approach in
So,
them?
there are 2 reasons in practice where you can see the scenario. Either it is, there is big portal hepatic adenopathy, or there's actual liver involvement. And if there's portohepatic adenopathy causing biliary obstruction, you can stent it and bring the bilirubin down. But there is also a paraneoplastic presentation of Hodgkin's where they present with liver, with very high bilirubin. And it's called the vanishing bile duct syndrome, where actually if you do the biopsy of the liver, you just see these bile duct ectasia. So you can't use vincristine, you cannot use Velban, you cannot use adriamycin. So in these situations, you need to just get the patient out of trouble. So you give them, actually I'll end up giving them low dose Cytoxan or low dose platinum and some prednisone and give it weekly like you do in like lung cancer or something. And you'll see that the bilirubin actually starts coming down. And once things have normalized, you can come in with your standard therapy. But you give them a chemotherapy agent like an alkylator or like platinum at low doses weekly to get them out of trouble, because those are metabolized by the kidney and not by the liver.
Sir, one more question, if I may.
Please go ahead.
So we talked about the dual 4, the broad heterogeneous group. If the same situation will end up in a relapse case, say we had done GDP into 2 and then we are again in a dual 2 kind of a situation with very minimal residual disease. So are you comfortable taking them to auto, or you would still treat them? Sometimes biopsy is not feasible.
So Dovell 2 is considered a CR.
Dual 4.
4. Okay. 4. So again, the transplant works if you can demonstrate chemosensitivity. Okay. So if you started out, you don't go by a Dovell score per se. Okay. Dovell score is one thing. But if you've started out with, say, a 5 centimeter mass, which had an SUV of, say, 8, and now that mass is 2 centimeters and the SUV is 4, yes, it's a Dovell 4, but the mass has also shrunk in size. Okay, so that shows the chemosensitivity. That scenario is okay to go to transplant. But if your mass hasn't even budged in size, then I think it's debatable whether it's sensible proceeding or switching therapy might be better.
Thank you.
Thank you. Samir?
Hi, ma'am. So my question is about, when you combine either brentuximab or one of the checkpoint inhibitors with chemotherapy, how do you sequence this? For example, I mean, in the echelon, they used ABVD. The brentuximab came after ABVD, right? It doesn't come before. Unlike in R-CHOP, when you use the
It's the same
rituximab
time.
first.
No, it's BVAVD. It's all given on the same day.
It's all given the same day. Okay, so
All
in
given
the
on the
trial, I read that it's given the day after
No,
ABVD.
no. All the same day.
And when you use checkpoint inhibitors, when you're combining it with some form of chemotherapy, do you give a sequence of like 3 doses of the checkpoint inhibitor, then follow it up with 3 cycles of the chemo, or do you give them together? And which one do you give first?
So it's not standard of care in anything. Okay, so we don't do it at all. The only place where it's used is first line salvage, where you can combine pembrolizumab with GND. Okay, so Pembro GND is a second line salvage, which is
When
now
they
also
soon
in the NCCN. And you
So
can,
when
it's
they
4
soon-
cycles.
Yeah, but soon they will probably be standards of, I mean, they'll soon get approved, these regimens that you spoke about. So there, would you
Right
use,
now it's given
how would you
concurrently.
sequence them?
It's given concurrently. It's not given as a single agent. It's given concurrently.
Okay. Thanks.
Krishna again, yes.
In a relapsed refractory Hodgkin's lymphoma, is there do you ever refer a patient for an allogenic transplant? Is there any room for that? Is there any indication
So
nowadays?
less and less. I think in 10 years, I haven't taken anyone to allotransplant now, because we have so many choices now. We have, you have brentuximab, you have the checkpoint inhibitors, that the role of allogenic transplant is becoming less and less. But yes, theoretically, if you have somebody who's primary refractory to chemotherapy, autologous transplant is not going to work in that patient. So you put the patient on, say, a checkpoint inhibitor, and then they get a remission. So there is data now that checkpoint inhibitors sensitize you to chemotherapy. So instead of rushing to an allo, we are actually, if they've responded nicely to checkpoint inhibitors, are taking them to auto. So it's a minority of patients now who are going to allotransplant.
Okay, thank you. Thank you very much.
Nidhi?
Thank you, ma'am, for the lecture. My question is regarding treatment of an advanced stage Hodgkin's lymphoma. If after IPET-2, there is only one single lymph node which is remaining, say a periportal lymph node which is persistently showing duals 4, and you go ahead with AVBD because otherwise the all other sites has responded very well. And then after 6 cycles, when you repeat the PET-CT scan, if that lesion is still persistent, so do you just irradiate and leave the patient like that, or you would go ahead with the escalation of therapy and auto transplant?
I would biopsy it.
But
I wouldn't do
sometimes
either of the two procedures blindly because it's very unusual that if you have somebody with advanced Hodgkin's that everything has gone away and you have one little lymph node left. So it's really important to biopsy it. Now, if you cannot biopsy it because of, I think that's where you were getting to. It depends on whether it's easy to radiate or not. I mean, you're not going to radiate the whole liver. So if you can do very targeted radiation, I do that. I mean, I don't think there's any data to support moving to transplant in that setting, but definitely biopsying would be I would make every effort possible to biopsy.
Right. So actually, I had a similar patient just 3-4 months back, and this particular patient, after 3 months, he progressed, and there was a florid disease all over. And even I did not understand that there was a single site which was remaining, and then the patient progressed after 3 months. So that is why.
Yeah.
Okay.
Few questions from the audience. One question is about the post-transplant maintenance with PV or CPI.
So the only approved agent right now is the BV, and it's only in high-risk patients. That means in patients who have relapsed within 1 year or who did not go into transplant in a PET negative state. Now, also remember that this trial, when the Athera trial was done, no one got BV as part of the induction regimen. So now if you're going to go do BV AVD for some patients and then they relapse, there is no role for maintenance BV because that's a completely different trial now. As of now, there is the data for maintenance with checkpoint inhibitors is still experimental. It is not standard of care.
Thank you. There's a question from Dr. Karim. 2 cycles of ABVD, PET negative. 2 more cycles of AVD, and after that treatment was stopped. Patient has now relapsed after 1 year and has got stage 4 disease. What will be the best treatment option?
Okay, so I assume the patient had initial advanced stage disease, and at that point, the therapy should have never been stopped after 4 cycles. So that was the first red flag there. You never stop after. I mean, I understand patients sometimes run away and they don't want treatment and things like that, but as far as possible, that's under treating a patient, and that's why this has happened. Now it's a year out, so you have to give a platinum-based salvage and take the patient to transplant.
Thank you. The last question over here is your experience of relationship between tuberculosis and Hodgkin. And if both are diagnosed at the same time, how do you plan your treatment?
Well, I mean, you have to treat the TB in parallel. I think y'all are much more experienced in answering this question than I am, because over here, we really don't see much tuberculosis at all. Here we see silly things like, valley fever and things like that, where you put people on anti-prophylactic, whatever the anti-infective prophylaxis is. So you would treat the tuberculosis in parallel and just make sure that the drug interactions are worked out. So I would work with our infectious diseases colleague to make sure that, we're not doing something which is going to interfere either way. Now, if the Hodgkin's is early stage and doesn't need treatment right away, early stage Hodgkin's can wait. I mean, when we diagnose pregnant women with Hodgkin's, we don't rush into treatment. We sometimes just observe them, right, till they deliver and then treat. So if it's not a situation which doesn't require urgent treatment, I would first 3 months treat the tuberculosis, get that well under control, and then start. But if you're in a situation where you have to treat the Hodgkin's and the TB, you would do them simultaneously.
Thank you. There are no other questions from the audience. Anybody over here wants to ask anything more? We have a couple of minutes. We have quite some time. We have 10-15 minutes. Okay, I don't see any more questions. Thank you, Dr. Ranjana Advani, for sparing your time being with us. It was
Sure.
It was extremely useful. Thank you.
Yeah. Thank you. Bye-bye.
So friends, as we have some 10 minutes, we'll have a break and reassemble at 8:25. So friends, we are back. And now the next lecture of the day is by our guest speaker, Dr. Lauren C. Pinter-Brown. To introduce her, she is MD, FACP, Health Sciences Professor of Medicine and Dermatology, Cow Family Comprehensive Cancer Center, UC Irvine, Orange, California. She is a hematologist oncologist, and she has been on the UCLA faculty since 1990. She earned her MD degree from UCLA Medical School, completed her internship and residency in internal medicine at Harbor UCLA Medical Center, and completed a fellowship in hematology oncology at the University of Southern California. She remained on the faculty at the University of Southern California in the hematology division until 1990, when she returned to the UCLA, having privilege at Olive View UCLA Medical Center and UCLA Center for Health Sciences. In July 2005, she joined the UCLA main campus faculty full-time as the director of the lymphoma program in the Division of Hematology Oncology. She has a long-standing interest in lymphoproliferative disorders, particularly in the skin and T-cell lymphomas. I invite her to give a talk on strategies for aggressive T-cell lymphoma, divide and conquer. Over to you.
Let's see. Can you see my slides?
Yes, perfect.
Okay. Thank you so much for including me in this great conference. And I wish you all a good evening. We're almost exactly 12 hours apart, so it's morning for me. And let's see if we can get this to advance. There we go. There's my disclosures. And I'll start with a case from my current institution, just to demonstrate how important it is to understand the subtype of lymphoma we're treating if we want to get good results. So this is a 36-year-old male smoker. He had axillary lymphadenopathy. He had a lymph node biopsy at an outside facility and was diagnosed with classical Hodgkin's lymphoma. And then he was lost to follow-up for 2 months. Then he presented to my institution with dysphagia and respiratory failure, actually requiring intubation. And a left cervical lymph node biopsy was performed and again reported as classical Hodgkin's lymphoma. CT scanning showed adenopathy above and below the diaphragm. His LDH was elevated, and he got doxorubicin, vinblastine, dacarbazine. And 1 week later, really the house staff could not extubate him. He was no better. And we obtained a second opinion pathology consultation, now showing anaplastic large cell lymphoma ALK negative. The FISH for DUS22 and TP63 were negative, making him what's called a triple negative. So the patient received an additional dose of doxorubicin, Cytoxan, steroids, and finally was extubated. He was then treated with 6 cycles of B-vedotin CHP. His PET showed a complete remission, and this was followed by high-dose therapy with autologous stem cell rescue. As a consolidation, he remains in remission, really at this point more than 2 years later. So our learning objectives this evening, really to emphasize that review by hematopathologists with expertise in the diagnosis of peripheral T-cell lymphoma really is essential, because the accurate diagnosis and subtyping of peripheral T-cell lymphomas allows us to make the best choice of upfront and subsequent therapies in an evidence-based manner for these patients. In the US, 5% of all non-Hodgkin's lymphoma are PTCLs. I'll actually show you a slide that I found regarding India, because I was just curious. And these originate from mature T-cell lymphomas. In the US, the most common T-cell lymphomas of mature T-cell phenotype are mycosis fungoides and Sézary syndrome. That represents the indolent side, which we're not going to be discussing today. And then PTCL not otherwise specified, the anaplastic large cell lymphomas, and nodal peripheral T-cell lymphoma with a T follicular helper phenotype are the most common aggressive lymphomas, and those will be the focus in this talk. So again, at least in the US, If we look at all T-cell lymphomas, they represent 6% of all the non-Hodgkin's lymphomas, which is part of the reason I think that we're so far behind in our understanding of these disorders. Let me make sure I didn't leave something out. All right, the difficulty in diagnosis is that they're a challenge both to the pathologist and the clinician, because many patients with peripheral T-cell lymphoma present with extranodal disease. So the pathologist is either looking at skin or intestine or some other extranodal site, and they really require feedback from the clinician as to what the clinical features are in the patient's presentation to render a diagnosis. It's a little bit even more important in T-cell lymphomas than B-cell lymphomas because of their presentation. There's numerous entities and they're all uncommon. And so that also presents an obstacle. There's a lack of reliable markers of clonality. In B-cell lymphomas, we have light chains. In T-cell lymphomas, we really don't have much other than T-cell gene rearrangement, which is fraught with problems. The specific genetic alterations in peripheral T-cell lymphomas have not been identified as completely as in B-cell lymphomas. And if you looked at the International T-cell Project, at least 10% of the diagnoses of PTCL are found to be in error. So our current classification has to do with, or one way of thinking about it would be how the patient presents. So if we look at mature T neoplasms, the bigger group of patients does present with nodal disease. That's peripheral T-cell lymphoma not otherwise specified, which unfortunately tells you a lot about the state of knowledge of T-cell lymphomas. Anaplastic large cell lymphoma, which comes both as ALK positive and ALK negative. This relatively new category called T follicular helper peripheral T-cell lymphomas, which encompasses angioimmunoblastic lymphoma. And then we have to the left some lymphomas that present almost totally extranodally, extranodal TNK lymphoma nasal type, the enteropathy lymphomas, hepatosplenic gamma delta T-cell lymphoma, and some that present with a leukemic phenotype. Adult T-cell leukemia lymphoma would probably be the biggest prototype. And as these are color-coded, the aggressive lymphomas are all white and the indolent lymphomas are yellow. So you see that most of these entities are quite aggressive. On the cutaneous side of things, it's really almost the opposite. Most of the entities, like mycosis fungoides, Sézaries, CD30 positive lymphoproliferative disorders, they're really indolent disorders, and I'm not going to deal with them this evening. So at least in the US, the most common peripheral T-cell lymphoma phenotypes are PTCL not otherwise specified, then called angioimmunoblastic lymphoma, and the anaplastic large cell lymphomas, ALK positive and ALK negative. And really peripheral T-cell lymphoma not otherwise specified in this pie, kind of coded as the darkest blue, represents the vast majority of the diagnoses. Interestingly enough, in T-cell lymphoma, as in all lymphomas really, there's a lot of geographic variation. So that if we look at, in this particular older study, Asian countries versus North America or Europe, we see that the subtypes are vastly different, with TNK nasal lymphoma much more common in Asian countries, and of course, adult T-cell leukemia lymphoma, which is endemic in certain parts of Japan. If we look at this contemporary paper, which is a retrospective study of a tertiary center in New Delhi, using the current WHO classification, we see too that in India, the distribution of T-cell lymphomas is a little different. So there's a large proportion of precursor T-cell lymphomas. Those are immature cells. I'm not dealing with that at all. But if we look at the mature T-cell lymphomas, we see that there's quite a lot of extranodal TNK lymphoma. It represents almost as much of the population as PTCL not otherwise specified. And then the ALK positive anaplastic large cell lymphoma is also very predominant here. And if we look at really all three groups, we see that the patients have a somewhat younger age than we would expect in North America. Mycosis fungoides here is really uncommon, 7%, which you won't believe makes up a quarter of my clinic population. So I'm going to speak about the entities in italics, which are the most common entities in North America, and there'll be some overlap here. These are all the mature aggressive T-cell lymphomas that are in the current WHO classification. And, you know, we first want to talk about how do we diagnose these? So immunohistochemistry is the most important thing to be used when a hematopathologist is trying to figure out if something's a T-cell lymphoma. Without that, really, there's no telling the difference really morphologically between diffuse large B-cell lymphoma and PTCL not otherwise specified. So this is an algorithmic approach adapted from the North American PTCL study group project. And you'll see that I'm going to focus a little bit on CD30, but that's included in the original or the baseline group of immunohistochemical stains. And then you see that there's some pan-T markers, CD3 and 5, CD10, which could be a T-cell marker if you're talking about a T follicular helper phenotype, and CD20 and PAX5 to rule out B-cell lymphomas. In the second level, you see things like PD1, Epstein-Barr, EBER, ALK, you know, as you're drilling down on the exact subtype of the lymphoma, and finally, T or B cell gene rearrangement. I'll spend some time on CD30 because a lot of this talk is going to be about a landmark study that really showed us a little bit better how we should treat patients initially. And it really is an important landmark because we haven't had anything but CHOP or CHOAP for these patients for at least 20 or 30 years, as long as I have been doing T-cell lymphomas. So when we assess CD30, immunohistochemical stains are the most common means of assessing expression, though sometimes flow cytometry might be used depending on what the sample is. And currently, really without a consensus, at least 10% positive cells define CD30 positive expression. But we'll see that in different trials, people have used different cutoffs. And if we look at that initial old T-cell project, just the addition of CD30 increased the reproducibility of the diagnosis of peripheral T-cell lymphoma, especially with anaplastic large cell lymphoma, by 40%. That's really a lot. So let's focus a little bit on anaplastic large cell lymphoma, which is an entity that has helped us define a little bit better what the optimal induction therapy is, and even how we might treat people in relapse or refractory disease. So up there on the right upper corner is a little picture of CD30 staining in anaplastic large cell lymphoma. We see that it's really wildly positive. So this is a very good example of how you might use the staining to diagnose and to help treat patients. And it is strongly positive at the cell membrane, as you see, and sometimes even in the cytoplasm. So we have this drug, brentuximab vedotin. It's an antibody drug conjugate that links a drug that is proprietary to that drug company, monomethyl auristatin A, it's like vincristine, to an old chimeric anti-CD30 antibody. And it was first studied, at least in T-cell lymphomas, in the relapse refractory setting for anaplastic large cell lymphoma in a phase 2 trial, where there was an astounding 86% response rate with 57% complete responses, noted with a duration of over a year. And that was really groundbreaking at the time. Some of these patients, 14%, had long-term complete remissions, even though they had relapsed or refractory disease. So this Echelon-2 trial was born, and it's a global, randomized, double-blind, double-dummy phase 3 trial of 452 patients, so very large in the T-cell world, or even really in the lymphoma world, comparing B-vedotin with CHP, so Cytoxan, adriamycin, and prednisone, obviously leaving out the vincristine from CHOP because there's overlapping toxicities, and comparing this with CHOP in the upfront treatment of patients with peripheral T-cell lymphoma, in which CD30 was found to be expressed in at least 10% of the malignant cells by immunohistochemistry. By design, the majority of the patients with intent to treat had anaplastic large cell lymphoma, and 22% of them had poor prognosis, ALK-positive anaplastic large cell lymphoma by by dint of having a high IPI. So the study by design is not powered to perform subtype analysis, and it really doesn't tell you as much about other types of peripheral T-cell lymphoma as it does tell you about anaplastic large cell lymphoma. But in this study, with a blinded independent review, patients that got the study arm, which was BVCHP, had a statistically significant improvement in median progression-free survival and also reducing the risk of death by 34%. So it really kind of tells you a lot about perhaps how you should approach at least anaplastic large cell lymphoma up front, and intimates a little bit about other kinds of T-cell lymphomas. We now have 5-year data, and I would say the most important thing that I got out of the 5-year data is that most of the patients that got peripheral neuropathy, because that is such an important toxicity of brentuximab vedotin, had resolution or improvement. And there were patients that, because of this, were able to be retreated with brentuximab vedotin, the median time to retreatment being 15 months, and they still had a 59% response rate. So if you're asking, this is great, but the patients still have a high risk of relapse, and then what am I going to do? We can still give BV to these patients. But what are the unanswered questions that this trial raises? Well, for me, one of the big unanswered questions is what do I do with people that don't have anaplastic large cell lymphoma? Because we know that in those patients, CD30 expression isn't close to 100%. It's variably expressed in approximately 30% of T-cell lymphomas. And if you look at the subtypes, maybe peripheral T-cell lymphoma not otherwise specified, the highest that's been reported is 30%. Angioimmunoblastic lymphoma, again, 30%. Extranodal NK lymphoma, perhaps higher. There's a very wide range in the reporting of CD30 expression. And then some of the other lymphomas and T cells subtypes really don't have expression that's that high. When we look at BV vedotin used in a relapse refractory setting, we see that these patients don't respond in the same way as anaplastic large cell lymphoma. So if we look at peripheral T-cell lymphoma not otherwise specified, the overall response rate was 33%, not 80%. And there perhaps is a signal with angioimmunoblastic lymphoma where the N here is very small, it's 13. The response rate was 54%. Many patients with angioimmunoblastic large cell lymphoma do have CD30 expression, but it's often in the cells that are responding to the malignant cell in the environment, perhaps responding to the Epstein-Barr virus that is frequently found within the specimen. So there is a little bit of a question how generalizable this data is to other kinds of patients. And both in this study and in multiple studies, there was no correlation seen between CD30 expression by central review and response. But obviously there is a difference here. And maybe we just never have enough patients in study to really see in a granular way how CD30 expression impacts on response. You might remember or know that in the past before this, our kind of go-to regimen was CHOAP. It was based on kind of scant data really from the German high-grade lymphoma study group. Here we see that the event-free survival in younger patients, particularly those with ALK-positive anaplastic large cell lymphoma, was improved by etoposide. And in the T-cell world, we're so frantic to improve patients' outcomes that we will accept perhaps not the most robust data to make decisions about treatment. So one question would be, what if they had done the echelon study and they had used CHOAP as the non-investigational arm? How would that have looked? And we aren't going to know the answer to that. But there is a small group of patients that was presented at last year's ASH, where you can see that you can actually give BV-CHEP followed by BV maintenance with or without an auto transplant in patients, and it is tolerable and efficacious. Here, the CD30 expression was defined as greater than 1% expression. Also, again, we wonder, what do we do with these patients after they relapse. And we see that we can treat these patients, retreat patients with brentuximab vedotin, that their outcomes are very similar to the original phase 2 relapse refractory monotherapy study. And so this remains a treatment option for these patients. Just a reminder about BV Dotin, there's the common side effects you might expect: infusion reactions, maybe a little alopecia, obviously neuropathy, very important because the majority of patients receiving the standard dose do experience some degree of neuropathy. And if you look in the package insert, it will tell you how to adjust BV for different regimens. This is primarily a sensory neuropathy that often presents with pain, but motor neuropathy has been reported. Cytopenias, of course, we would expect because it's a chemotherapeutic agent, but some of the things that maybe aren't top of mind are that the chemotherapeutic drug here is like vincristine. So you would reduce in the setting of mild hepatic dysfunction. Sometimes patients can anaphylax to BV Dotin, and tumor lysis syndrome has occurred. There is a black box warning regarding the possibility of a progressive multifocal leukoencephalopathy, and there has been some concerns that BV Dotin allows the reactivation of viruses. Stevens-Johnson and toxic epidermal necrolysis have been seen, and pancreatitis has been reported. So I generally, when I'm treating people with BV, include a lipase or some indication of pancreatitis. Sometimes it's so hard if a patient tells you they have epigastric discomfort or nausea and vomiting to sort out pancreatitis from perhaps a toxicity of brentuximab vedotin that is not pancreatitis. So if we look at all the subtypes of peripheral T-cell lymphoma, we can start to think a little bit about what the induction therapies should be. So if we're talking about PTCL-NOS, we could consider BV-CHP for patients that have CD30 expression in their tumors. We can consider CHOP, CHOAP. There's very little data for dose-adjusted EPOCH, but there is a paper. If we're talking about nodal lymphomas of T follicular helper cell origin, at the present time, the recommendations would be the same. There's a big alliance trial looking at different induction regimens. Perhaps we'll see that using specific regimens for angioimmunoblastic lymphoma or T follicular helper PTCLs will emerge. For anaplastic large cell lymphoma, BV-CHP, I think, would be the current induction of choice. And then we have some specific regimens. Extranodal TNK lymphoma, in my mind, in addition to radiation for early stage lesions or for stage 4 or extranasal lesions, some chemotherapy that includes L-asparaginase, I think, is mandatory, because L-asparaginase as a single agent can induce complete responses. It's extraordinarily important when we're treating this entity, which is really relatively chemo resistant. There's a specific regimen that's been published for ETL, intestinal T-cell lymphoma, called the Newcastle regimen. I'll show it to you in a second. Some have advocated upfront ICE for hepatosplenic T-cell lymphoma. And then we have two very unusual lymphomas, for which we don't have very good information about how to treat when we need to give chemotherapy. So regimens for TNK nasal lymphoma, kind of the prototype. The first chemotherapy regimen that really showed activity miraculously is the SMILE regimen. SMILE incorporates a lot of drugs that do not participate in multi-drug resistance. It incorporates L-asparaginase. You can use modified SMILE that has long-acting asparaginase. I don't know if anybody's asking a question or they're not muted. But there's other regimens that are easier than SMILE. One is PGEM-OX, which can be given more readily in an outpatient regimen, and there's a couple of different ways to administer that. And then this is the Newcastle regimen for enteropathy-associated T-cell lymphoma. It's kind of souped up CHOP with IVE, ifosfamide, and etoposide, intermediate dose methotrexate, and it absolutely incorporates auto transplantation if the patient goes into remission. What else can we do for these patients? So this is a very old slide. You can see it has an old slide template, but unfortunately our results have not gotten tremendously better. So the cure rate for peripheral T-cell lymphoma, if we look at all comers, is about 20%. It's higher for ALK-positive anaplastic large cell lymphoma as a group, although there's some patients even within that subtype that don't do well. So people have turned to consolidation with transplantation as a means to try and prolong people's disease-free interval and perhaps cure a higher number of patients. There are some groups of patients, as I mentioned, even in anaplastic large cell lymphoma, where there are certain considerations for transplantation. If we're looking at ALK-positive anaplastic large cell lymphoma, if we look at the IPI, patients with high IPIs, this is the same IPI you would use for B-cell lymphomas, they actually don't do very well. So those patients would be considered for upfront autotransplantation. And then in ALK-negative anaplastic large cell lymphoma, we have one group here you can see that actually do quite well, as well as ALK-positive anaplastic large cell lymphoma with just 22 mutations, and we might consider not transplanting that group. So when we look at upfront stem cell transplantation, we realize that most of the data is retrospective, that the prospective trials weren't randomized, that there's multiple confounders when we look at the trials. Some include even low risk ALK-positive anaplastic large cell lymphoma patients. But we still see that a higher progression-free survival is suggested for those patients. Some people have raised the question whether the patients would have done well anyway without stem cell transplantation, the fact that they make it to stem cell transplantation. But in general, we can consider upfront autotransplantation as a consolidation if the expected 5-year overall survival is under 50%. Even when we look at Echelon 2, there was a post hoc exploratory analysis, and we see that the patients that went on to transplantation in this trial actually did benefit. So there's 2 points you can see in this data. Let's look at ALK-negative systemic anaplastic large cell lymphoma. 67% of the patients achieved a CR and 36% of them made it to transplant. And that's a theme that you see in peripheral T-cell lymphoma very frequently, that you can attain sometimes a complete remission in these patients, but it is very short-lived. And they often don't even make it to transplantation. Their complete remission doesn't last long enough. In non-anaplastic large cell lymphoma, you see the same phenomenon. 59% of patients achieving CR, 29% of them going to transplantation. But again, we see the progression-free survival estimates favor the use of transplantation. And we see that pretty much across the board in phase 2 or 3 studies, and even in registry data like COMPLETE. So that in the absence of validation in a prospective randomized trial, though this is a controversial issue, it has become standard practice at many institutions. And at my institution, we would take people to autotransplantation and consolidation. So this is a list of patients where you might consider referring them for stem cell consideration. Patients with high risk ALK-positive anaplastic large cell lymphoma, people that have positive TP63s or triple negative anaplastic large cell lymphoma, PTCL-NOS, those patients with nodal PTCL of T follicular origin, ATLL, if we have a fit patient, would go immediately to allotransplantation. People with extranasal, extranodal TNK lymphoma might use this in consolidation. As I mentioned, the Newcastle regimen. Hepatosplenic T-cell lymphoma is usually taken to allotransplantation up front, as is primary cutaneous CD8 aggressive epidermotrophic cytotoxic T-cell lymphoma, such a mouthful. And even you might consider it in some patients with extracapsular breast implant associated lymphoma. So we generally tend to think of this as a very indolent disease, but in fact, when the disease extends outside the capsule, it almost behaves like ALK-negative anaplastic large cell lymphoma. And those are primarily the patients we see who expire from this disease. So moving along to the relapse refractory setting, let's look at an angioimmunoblastic T-cell lymphoma or nodal lymphomas of T follicular helper origin as an example of how we might pick which relapsed or refractory drugs to use. So this is an entity that is defined by 2 or 3 T follicular helper related antigens. It's a new entity in the most recent WHO, and those antigens include PD1, CD10 because the cell comes from the follicle, BCL6, CXCL13, ICOS, and other stains that you can do with immunohistochemistry. Even some patients with PTCL not otherwise specified can then be removed from that kind of garbage can group into this group by the use of these immunohistochemical stains. There's actually a large group of these patients, approximately 30%, who really have a T follicular helper origin. And not only does it allow kind of for a better diagnosis and better treatment, but it informs us of why we see certain clinical features in these conditions, such as autoimmune phenomenon, polyclonal hypergammaglobulinemia, and most importantly, the association of B-cell lymphomas. Because these cells live in the follicle and very closely interacting with B cells, and when the B cells are stimulated by the Epstein-Barr virus that is associated with the T follicular helper PTCL, they can sometimes pick out a clone and become diffuse large B-cell lymphoma or other B-cell lymphomas, either post the diagnosis of T-cell lymphoma or concurrently. So this is one entity where the genetic abnormalities are actually fairly well defined and include TET2, IDH2, DNMT3A, RHO-A. And when we look at these, many of these mutations involve genes that encode for epigenetic modifiers. So a lot of what we've seen clinically and in research that's being planned involves the use of epigenetic modifiers for this particular entity in PTCL. So if we look at, these are FDA approved agents for relapse refractory PTCL in the US. Actually, romidepsin doesn't have its FDA approval for PTCL anymore, but we still have an HDAC inhibitor called belinostat. We have pralatrexate, which is kind of like chemotherapy, kind of a fancy methotrexate. We have brentuximab vedotin, and for ALK positive anaplastic large cell lymphoma, we have crizotinib. But if we look at, for instance, HDAC inhibitor versus chemotherapy, we see that there appears to be a signal in the T follicular helper phenotype that an HDAC inhibitor, which is basically an epigenetic drug, might have a much higher response rate in angioimmunoblastic T-cell lymphoma. And if I was going to treat somebody with T follicular helper phenotype lymphoma in a relapse refractory setting, I would pick an HDAC inhibitor before I would pick most other things, with the exception of perhaps brentuximab vedotin. But we have to realize that the studies here are vastly different. Belinostat was a very large study that was used for drug registration. And the evidence for B vedotin, as I said, is a very small number of patients. Looking at the future, how else can we try and sort out, these entities? So we have PTCL-NOS, the garbage pail, and we do know that within this group, there are gene expression microRNA profiling studies that have delineated 2 biologic and prognostic subgroups with either increased expression of GATA3 or increased expression of TBX21. These are transcription factors that regulate gene expression profiles in TH cells, directing the cell either into a TH2 or TH1 phenotype. And you can use immunohistochemical stains to figure out these groups. This is really kind of in its infancy, but you can imagine how you might start to use it in the future. So increased GATA3 expression is associated with the loss or mutation of tumor suppressor genes, which target P53 and PI3 kinase pathways with gains in STAT3. And these patients have especially poor outlooks. The increased TBX21 group is enriched for genetic mutations regulating DNA methylation. So you can see where We do have studies looking at PI3 kinase inhibitors. I'll show you one of them. We have studies looking at DNA methylation. So you can see going forward that you could design a study looking at PTCL-NOS, looking at these two groups and seeing if a particular incorporation of one drug or the other might be helpful. And perhaps this alliance study might help in that regard. So in the future, basically, as in the past, we're repurposing old drugs that are mainly used for B-cell lymphomas. And I'll show you just a little bit of data about duvelisib as an example of a PI3 kinase inhibitor, a little bit about azacitidine. And then, though I don't have a slide about it, you might look at this Blood article, which looks at ruxolitinib, a JAK-STAT inhibitor. They had all kinds of histologies of T-cell lymphomas, but I think of interest, there seemed to be a signal in large granular lymphocytosis and adult T-cell leukemia lymphoma, an entity, actually both entities, that are very rarely studied and really need treatment options. So duvelisib, the phase 1/2 study utilized a single dose, 75 milligrams POBID. The response rate was 50%. There were some complete responses, and this engendered a much larger phase 2 trial that it's called PRIMO. And in this trial, the initial dose was high, 75 milligrams POBID, but then after 2 months, the dose was reduced because, as we all know, it is a challenging problem to use PI3 kinase inhibitors as a chronic treatment because the more you use them, the more autoimmune phenomenon you see. So this was a kind of an attempt to reduce the dose, to reduce the toxicity so that the patient could stay on the drug longer. So you do see an overall response rate duplicated here at about 50%. There are some complete responses. I'm a little bit disappointed with the duration of response, which averages around 7 months. So I think this is not kind of a home run, but could be used in some patients as a bridge to transplantation. It might be something that's incorporated with chemotherapy. That's what's happening in the Alliance trial. So we'll see where this goes, but it's at least confirms the concept of using a PI3 kinase inhibitor in T-cell lymphomas, which is a relatively new concept. Azacitidine, there are some case reports and some smaller case studies using it as a monotherapy, primarily for angioimmunoblastic lymphoma because the studies were done before the current WHO. And there is this one phase 2 trial, unfortunately using romidepsin with azacitidine in both treatment naive and relapse refractory patients. So there's a little bit of confounding information there because the patients were mixed. However, the overall response rate was very high, and there seemed to be a signal in the T follicular helper phenotype. So going forward, we might, look at these kinds of drugs, and obviously there's other studies going forward, attempts at doing CAR-Ts, attempts at doing bispecific antibodies for T-cell lymphoma, both of which are kind of fraught with problems. Newer versions of anti-CD30 antibodies are the big things, I think, in trial going forward. So in conclusion, the aggressive peripheral T-cell lymphomas are a very heterogeneous group of uncommon lymphomas of mature T lymphocytes. In the US, they're dominated by systemic anaplastic large cell lymphoma, PTCL with a T follicular helper phenotype, and PTCL not otherwise specified. And although the diagnosis and subtyping of these lymphomas may be challenging, it is really important to understand as best you can the subtype so that you can select the optimal treatments for patients because it really probably does make a difference for those patients. I focused the talk on the 3 most common subtypes of aggressive PTCL in North America and tried to give examples of how current knowledge might dictate the choice of therapy, consulting referrals, inform rational targets for future clinical trials. But finally, remember your pathologist and your clinician. They're definitely a team for T-cell lymphomas. because of all the extranodal presentation. And with this, I'll stop. And if there's any questions or comments, I'm happy to entertain them.
Thank you so much. That was great. Enjoyed listening to you. A real update. Dr. Krishna has a question.
Thank you very much. If a patient relapses PTCL NOS after chemotherapy, would you recommend an autologous transplant or an allogenic transplant in the relapse setup?
That's a good question. I think an auto transplant would be fine if they didn't have one up front and they were able to attain a complete response. But that's going to be an even smaller group of patients than the group that got upfront transplantation. If they've already received an auto transplant, then I suppose, you know, unless there was an extremely long duration of response, which unfortunately is not particularly seen in this patient group, I'd probably go to allogeneic transplantation if the patient was eligible, or, you know, or not some clinical trial. I don't know how much you look at NCCN guidelines, but basically for all time in T-cell lymphomas, the current recommendation is always clinical trial for whatever, if it's upfront, if it's relapse refractory, always clinical trial.
Thank you. Thank you very much.
Thank you, Dr. Krishna. Dr. Arihant.
So thank you, Dr. Lauren. Couple of questions for you. So
Okay.
first is, where does interim PET or what is the role of PET in the entire T-cell lymphoma scenario?
Well, that's a big problem. So there are some studies about PET and PTCL, and I would say they're very mixed about the utility of PET. I tend to use it, but I realize it's not as reliable as aggressive B-cell lymphomas, where, you know, PET avidity for, as an example, diffuse large B-cell lymphoma is close to 100%. So I think we need to do more work with that because there's different camps. Some people very much believe in it and some people don't, and that's because the data is not very clear. And when we look at indolent T-cell lymphomas like mycosis fungoides, it becomes even more complex because there you often see lymphadenopathy that has kind of low avidity. And I would say the majority of the time, the lymph nodes are peripheral, like axillary or groin, and they represent dermatopathic lymph nodes. If you were to biopsy every single one of them, you would find out there's really no demonstrable, you know, tumor there that you can see under a microscope. So there, it becomes even more problematic because you have so much false positivity. So I can't give you a good answer other than to tell you I do use PET scan, but I don't know if you all have this problem, but in the US, insurance companies push back a lot about PETs. So if an insurance company pushed back on a PET scan on a PTCL patient, I probably wouldn't argue it and be able to argue it as vigorously as I would say for diffuse large B-cell lymphoma or Hodgkin's, where it's very clear, you know, what the utility of PET is.
Thank you. Another question. So in ALK positive ALCL with a IPI which is more than 2, the role of auto transplant as a consolidation in CR1, when we are using the CHOP based approach, and second, when we are upfront using brentuximab. Does brentuximab obviate the need of auto transplant?
I don't think so. There's been a lot of discussion about it because it obviously improves the outcome. But if you look at those patients in the Echelon trial that went to transplantation, they still benefited from transplantation. So even though I think BV-CHP represents an improvement over CHOP, I still think I would transplant patients based on that data. Of course, it's an ad hoc analysis. It was never intended when the trial was designed. But I think it actually tells you a lot about kind of that drug combination, that it's better, but it's not a home run for these patients. And two, patients with ALK positive ALCL tend to be very young. and they would tolerate transplantation well. So you wouldn't have as much fallout from transplantation as other PTCLs where perhaps the patients are much older or more debilitated, can't make it to transplant. With ALK-positive ALCL, you know, you're primarily talking about 20 and 30-year-olds. So I haven't changed my practice in that regard based on Echelon and based on that post hoc assessment.
One more question. Allo transplant in CR1. Which subset of T-cell lymphomas?
Yeah, so they're primarily the ones where you would never hope to get another CR or close to a CR. So I would say the one that comes to mind the fastest is hepatosplenic T-cell lymphoma, or ATLL, because if you're lucky enough to get a response in those patients that is durable enough to get to a transplant, you take your best shot the first time. And unfortunately, even doing that, the majority of those patients relapse. But those are two examples that I can think of. The other example would be the aggressive entities in skin. So like gamma delta T-cell lymphoma of the skin, the CD8 epidermotrophic T-cell lymphoma of the skin are extremely aggressive disorders, even though they only involve skin. And also very hard to get somebody in remission. But if I was lucky enough to get somebody with a decent response that healed up all the ulcers that they get with those entities, I would immediately go to allotransplantation because it's unlikely they'll get a second chance.
And
I think
one
in my mind,
last,
those would be the entities.
Advanced NK T-cell lymphoma treated with intensive regimen, say DEVIC or a SMILE, and attained a remission. You transplant them all, or if they are fit, or
I do. I consolidate with an auto transplant, even though they're in response, because that too is a patient group where they have a very high chance of relapse versus limited to the nose, where actually they have a pretty good outcome. But in the US, we actually did a retrospective trial, a retrospective look at those patients across institutions. And what was kind of interesting is that they have a lot of late relapses, even the nose, just the nose. So I don't think they're maybe out of the woods at 5 years, but you know, they will do well for a prolonged period of time. And now we have many drugs to try and salvage patients with PD-1 inhibitors, BV, because most of those patients have CD30 expression on their tumors. So we do have some means of getting those patients back in remission and then transplanting them. But I do, because the patients with extranasal disease, a very aggressive disease, often have hemophagocytosis. I do, if I get them into a CR, auto transplant them in consolidation. And they seem to do quite well that way.
Thank you. Dr. Krishna?
Is there any role for a post-transplant maintenance with the brentuximab, like Hodgkin's lymphoma in CD30 positive ALCL after transplant?
It's a great question. And I've started wondering if I should be doing that, but the only trial you have is that abstract from ASH that I showed you. So it wasn't a randomized trial. They just show that it's feasible. Well, you know, you might know that it's feasible from Hodgkin's. So we don't have any data, but I think it's a great idea. And I think in certain patients, if I think they have an extraordinarily high risk of relapse, and I can get an insurance company to pay for that, I might well do it, just like you would do in Hodgkin's, high risk. But we have to realize there is zero data. And I don't know, I haven't seen a trial like that, but it would be a really important trial to do, I think, on a larger scale. I think that'd be really, really important.
Okay, thank you.
Thank you. The question from the audience, would azacitidine be an agent for PTCL subtypes like AITL, TFH, phenotype of T-cell lymphoma.
I'm sorry, I missed the beginning part of the question.
Will azacitidine be an agent for this lymphoma?
Yes, I think so. You know, it's unfortunate that the investigators that combined it with an HDAC inhibitor just happened to pick one that we don't have access to in this setting anymore. It would be nice to maybe try and duplicate the study in a relapse refractory setting with belinostat. I don't know if that's really going to happen, but certainly there are case reports and small case studies of azacitidine as a single agent. And I definitely think that should be part of the armamentarium for that patient population. As well, we probably shouldn't forget that back in the day, before we had all these drugs, the other kinds of things that could be used for that patient population in a relapse refractory setting are things like cyclosporin, prednisone. I mean, you know, they did work. They may not be very exciting anymore to us, but I think that, you know, be mindful when you see studies of that patient population, because most of the studies, there's a signal specifically in angioimmunoblastic lymphoma that many of these newer agents work much better in that patient population. So I think that there's going to be a burgeoning of choices for that particular patient group. And sadly, the other you know, subtypes may not have quite as many treatment options that are good. And that's just kind of the way it looks in all of these new drugs. There seems to be a signal in that patient population. I bet there's going to be a long list of things we can use in the relapse refractory setting that are easy for the patient to tolerate for long periods of time.
Thank you. Another question from the audience. T-cell lymphoma with positive cytotoxic IHC markers. Will you consider treating them with L-asparaginase-based regimen on the lines of nasal T-cell?
What a great question. I've never really thought about it. I really haven't thought about it. I can't remember the last patient I even saw like that. I guess in a relapse refractory setting, I wouldn't have a problem with it because there's not very many choices. Upfront setting, I don't know if we can really extrapolate regimens for TNK nasal lymphoma, which is a very specific entity, you know, to other entities that may share some pathologic features. I don't know, I'd be interested in what all of you think.
One more question. Is there a role of upfront allotransplant in HTLV-related lymphomas?
Yes. So particularly for the acute or lymphomatous subtypes, there's definitely a role, but be mindful if you happen to use mogamulizumab as some part of their therapy, that there's a concern that there is an increased risk of acute GVHD because of the way mogamulizumab works. It basically is knocking out your Treg cells. And so people have come up with different kind of concepts of how to go forward, either by having a longer washout, probably not the best idea for these patients, or giving more intense anti-acute GVH treatment post-transplant. So just be aware that that's a particular problem in that patient group because so many of them receive treatment with mogamulizumab. But quite definitely, if I had a patient that was fit, that had the more aggressive subtypes of ATLL, and I was lucky enough to get them into close to a CR or in a CR, I would definitely take them to allotransplant. The other subtypes can behave in an indolent fashion for a very long period of time. Unfortunately, they often transform, but those patients I would not. And I think in those patients, the bigger question is, you know, what would be the role of saying using a drug like mogamulizumab in somebody with chronic or subacute ATLL to try and prevent transformation, and we don't have an answer for that.
Second part of this question is, will allotransplant eliminate HTLV also?
No. No, wouldn't that be nice? No, not that I'm aware of. And I wish we had drugs to treat the virus, which we really don't, unfortunately.
Okay. Do you see localized T-cell lymphomas, and is there a place for radiotherapy?
Localized T-cell lymphomas, and is there a place for?
Radiotherapy.
Oh, well, you know, back in the day, when I would see like stage 1 or stage 2 PTCL, I kind of extrapolated from diffuse large B-cell lymphoma, gave them foreshortened chemotherapy and maybe radiated. And I was very displeased with the results. So in my mind, and I'm sure there would be controversy about this, I don't really care what stage they are. They're all going to get treated the same way. I feel like even when you're lucky enough to have a patient with low stage disease, they unfortunately are still at risk for relapse and for death. And that's just been my personal experience. I'm sure other people might feel differently, but for me, it almost makes no difference.
In AITL with autoimmune hemolytic anemia, do you use rituximab?
Sure.
Right.
Sure. The presumption there is that there's a B-cell clone causing that. And I would approach the B-cell clone just like you would approach any immune thrombopenia. If it doesn't go away with prednisone, I think rituximab's totally fair. There was a period of time actually where people incorporated rituximab in the treatment of angioimmunoblastic lymphoma, trying to get out the EBV virus that's often found, though I found the literature not very convincing, but there was a period of time where people were advocating that. So I think for sure, if you have clinical demonstration that there's a B-cell clone, that would be totally appropriate.
One last question is there a role of prophylactic CNS therapy if the disease is close to the spine?
You are asking such great questions. So this is a thing that's gone back and forth too. When I was trained eons ago, everybody with T-cell lymphoma got prophylaxis. I don't think that it's actually very important anymore. And then probably where your question would be most relevant, which we always debate about, is TNK lymphoma. So some people, they get very upset by the concept that it's so close to the brain because it's in your nose. And shouldn't those people be prophylaxed? And I think, again, that's somewhat controversial, but if you look at the clinical data, CNS involvement isn't very common. So I personally don't prophylax those patients, nor do I actually look in the absence of symptoms. And that might be counterintuitive.
Thank you. That is the last question. Well,
great question.
Any question from the faculty here? Okay, none. Then thank you so much, Dr. Lauren. That was fantastic. Really
Thank you very much. Enjoy your evening, and hopefully I'll see you for real.
I do.
Bye.
Bye. And thanks to all of you. Have a wonderful dinner at your home with your family. We meet tomorrow at 6:30.